Welcome back, everybody. So I'd like to invite Becky, Kath and Danielle to come forward whilst I read your bios. So thank you very much for providing them. So Becky Walsh is the Patient Reported Measures Program Manager. She's worked in public healthcare for over 25 years and has extensive experience including frontline service provision, project management, implementation of district-wide initiatives, organisational development and learning, innovation projects and clinical governance. Becky is currently a Patient Reported Measures Program Manager at South East, a position she has held for the last 2 years. In this role, Becky is responsible for clinical engagement, system monitoring and support, process improvement and implementing models focused on supporting staff to provide high-quality, safe patient care. And your fun fact is you love a good dad joke. Lovely. Kath. Yeah. Oh, yeah. Yes.
You threw me right straight under that bus.
Yeah.
All right, I do, because I knew this was coming. Yeah. All right, so the first one I have for you is, why don't prawns make good friends? Because they're shellfish. Another one?
Okay, we welcome Kath. Kath is the Patient Reported Measures Program Manager. She's hospital trained registered nurse by background. So am I. Yes. Yeah. No, we're not. You've had a long career to raise 3 beautiful daughters and you returned to nursing in 2008 at St George. You've been very fortunate to have had great opportunities. You've worked as a nursing unit manager in both outpatient and inpatient settings. Throughout your career, you've recognised the importance of listening to patients as they can provide us with a unique insight into the service we provide. You are currently the Patient Reported Measures Program Manager, and you feel that it brings your skills together nicely as you support clinicians to use patient feedback to inform care and service provision. And your fun fact is you're a mother of 3 beautiful chickens. Oh, and 3 beautiful, gorgeous daughters. Well, yeah. Thanks, Kath. We welcome Danielle. Hi, Danielle. You're a senior OT at Prince of Wales, and your fun fact is that you share your birthday with your mum. Yes.
And Natalie.
Oh, and Natalie. Well done. Thank you, ladies. Now, do you give them that?
Okay. Can everyone hear me? Great. So thanks very much for inviting us here to speak to you today. Kath and I are going to give you a quick overview of the Patient Reported Measures program and the HOPE IT platform that we're using for some falls programs here at SESLHD. Just as a bit of context, HOPE isn't a goal, it's actually an acronym, and it stands for Health Outcomes and Patient Experience, and it's the purpose-built IT platform that's being implemented across New South Wales Health to support a consistent and structured approach to capture and utilise patient-reported outcomes and experience measures in real time. Once we've gone through patient-reported measures and the HOPE, a little bit about the HOPE platform, we'll hand over to Danielle, who's going to give us her first-hand experience of using patient-reported measures for falls prevention as part of the Stepping On program at the Prince of Wales Hospital. And I'd just like to let everybody know that at the end of the presentation, if this is something that you'd like to consider for your service, this is what Kath and I do. We work for South East and Sydney Local Health District, so please reach out to us and our contact details are on the last slide. No, doesn't like that. So what's this all about? It's about value-based healthcare, and the New South Wales health system is evolving from measuring volumes such as activity and outputs to measuring value to our patients in terms of their health outcomes and their experience of care. So value-based healthcare is centred around this quadruple aim that you can see here on the screen of effectiveness and efficiency of care, the experiences of providing, so importantly for you as clinicians and receiving care, but really importantly, the health outcomes that matter to our patients. And a patient focus is vital to achieving value-based healthcare, and the Patient Reported Measures program is a key enabler of this vision. So the Patient Reported Measures Program is a statewide initiative being led by the Agency for Clinical Innovation and is being rolled out across New South Wales Health with an initial focus on implementation in clinical programs that are connected with a Leading Better Value Care or integrated care initiative. One of those is Falls in Hospital, as you can see here on the screen. The Patient Reported Measures Program enables patients to provide direct and timely feedback to their care team on the health-related experiences and outcomes that matter most to them. And patient-reported measures can be grouped into two categories, as you can see here on the slides. Everybody loves acronyms. So patient-reported outcome measures, or PROMs, are surveys that capture information about a patient's health, quality of life or functional status as it relates to their health care or treatment. It's important to make the distinction that PROMs are directly reported by a patient without any interpretation by a clinician. Patient-reported experience measures, or PREMs, are surveys that gauge a patient's experience and satisfaction with the care that they've received. Now, PREM surveys as part of our program are completed anonymously, and those results are used to drive service improvement. Patient-reported measures also provide individual service and system level information. At an individual level in daily clinical practice, patient-reported measures are unique and complementary measures used alongside objective clinical outcome measures to inform care planning and management. At a service level, aggregated PRM data can be analysed to review the effectiveness of treatments, benchmark against best practice, measure the effectiveness of quality improvement activities, and also to identify variations in care, cost and outcomes. At a system level, the Patient-Reported Measures Program will help decision makers establish and evaluate policies to benefit whole populations. The other thing I just want to point out here is that using patient-reported measures can also assist our services in meeting requirements for National Standards 2 and National Standards 5 as we move towards short notice accreditation in the coming years. So why are we doing this? Patient-reported measures provides a way for clinicians to improve communication with patients and supports comprehensive care. Clinical indicators don't always tell us about how a person is actually feeling. Patient-reported measures capture and document patients' voices to better understand the patient's needs. So instead of focusing on what's the matter with you, it shifts the focus to what matters to you. They also collect information on characteristics that impact a person's health and well-being, which can be difficult to measure physically, such as fatigue or quality of life. Using patient-reported measures in daily clinical practice also gives clinicians consistent and standardised information on patient symptoms and concerns and allows you to track and trend both individuals and whole patient cohorts. Completing patient-reported measures gives patients a greater say in their care and enhances interactions between clinicians, the person's care provider and the patient to support shared care planning and decision-making. It can also increase a patient's ability to self-manage and potentially avoid hospitalisations because a person who's better engaged in their care is more likely to demonstrate adherence to treatment outcomes, which can lead to improved outcomes. As you can see, I'm winding up there. I've said enough. I'm going to hand over to Kath and she's going to tell you a bit more about PRMs for falls.
Thanks, Becky. Thank you. So how does patient-reported measures fit into falls? As Becky's mentioned, there are 2 outcome measures specific to the falls program. One of those is a condition-specific endorsed tool known as the Falls Efficacy International Scale. We also have a quality of life outcome measure that Becky's mentioned as well, and I'll talk a little bit more about both of those measures in a moment. Experience measures, we have them for both outpatient and inpatient, and a few recommendation collection points, which really aren't all that onerous, but it just gives you a guide on when to capture patient-reported measures in the inpatient and outpatient settings. Questions have been co-designed by consumers, tested for health literacy, and they allow patients to give direct feedback about their experience, and we can use that to inform the care and service improvements that might be required for our services. So the condition-specific endorsed tool for falls in hospital or outpatient falls is the FESI. And basically the FESI collects the patient's fear of falling. So we've heard this morning that falls really are a significant cause of morbidity and mortality for our patients. And fear of falling is really common in our elderly patients. So, and we've heard about the cost that we incur if a patient falls in hospital, around about $7,000. So if a person's had a fall or they know someone that's fallen, it can really induce a fear in these patients. And this endorsed tool is a really good way for us, without interpretation from any of our other clinical measures that we use, to have the patient's perspective on their fear of falling. We have a quality of life tool, and the endorsed quality of life tool for falls is the Promise 29. And the Promise 29 basically asks questions about a number of indicators like physical function, anxiety, depression, fatigue. So you can see how patients functioning out in their life and make the necessary referrals if needed. So just a little bit more about the HOPE platform. This is where we collect and collate all the information. The HOPE platform's been designed with consumers, clinicians in partnership with the ACI, as Becky said, and eHealth. It facilitates that real-time feedback. It works with algorithms in the background, so there's no need to add up any scores, and it's got some really nice analytics and reporting functionality. Available in 10 translated languages for both the outcome and experience tools. So you can set it up that your patient can read it in their own and respond in their own language, which is a real bonus. Where are we at? So we've implemented patient-reported measures in a number of settings across the district. We've got 3 outpatient settings that we're currently using patient-reported measures in. We've got the Prince of Wales Stepping On program. We've got 2 programs at War Memorial Hospital that use patient-reported measures. We've got the Stepping On program there at War Memorial, and we've also got IREAP. And IREAP are actually going to provide some slides that will be sent out as part of the education pack that's sent out following today. So there'll be some more information about the IREAP War Memorial patient-reported measures. We have 2 inpatient locations. They're both at Sydney Eye. And it's been great to work with the team there, really trying to do the best for the patients in that inpatient setting to understand our patients' fear of falling. We've also going to go live with our older persons mental health unit with their Stepping On program in April as well. So that's exciting that we're rolling it out in quite a few different locations. Becky said a little bit about what we do. So we're always here to help and support. And if anybody's interested, our details will be on the last slide. I'm just going to hand over to Danielle to talk to you about her experience with patient-reported measures.
Oh, sorry. Make it awkward. Hello, I'm Danielle. I'm going to talk to you a bit more about how we practically implemented these measures into our already existing Stepping On group. Given the topic of the forum, I imagine that there's a lot of people here that are quite familiar with Stepping On, so I'm not going into Stepping On, more just how we coordinated it with our Stepping On group. That's what I just said, sorry. For those of you who are familiar with Stepping On, you know that we already take our strength and balance outcome measures in week 1 and week 7. So they're your kind of timed up and go tandem stance measures. So it just made sense that when thinking about introducing the patient-reported measures that we included them at these same time intervals. So that's what we've done. We take our pre-measures in week 1 and our post-measures in week 7. There was some concern when thinking about implementing the HOPE platform with older people that they may not like to use iPads. So we tried to kind of think ahead, and we had paper versions available. And the plan was to send out some paper versions in the intro packs in week 1 and give them to them in week 6 to bring back in week 7. We also recognised that there would be an increased load by introducing kind of 2 to 3 measures in these weeks. So we made an effort to engage allied health assistants or allied health students. The first time we ran it, Becky and Kath came along to help. They're very helpful if you're thinking about including it, a little spruik. And just really simple things to think about around the admin is we added checkboxes on our initial list for, attendance or were the measures completed. Make sure we put in those patient reported measures. Were they completed? Were they offered to the person? It wasn't something that we made mandatory to attend the program. And finally, we recognised that the need for this to be documented in EMR. So we created some simple templates so we could easily capture it and document it. But as was mentioned, hopefully it will be integrated with EMR in June. So that will make our lives a little bit easier. So I thought I'd go through a little bit of the data we gathered so you could see whether it's helpful. I think it was. So we used this in 3 stepping on programs. Admittedly, the groups were smaller in size because of COVID restrictions to room sizes and whatever, but I think we could use that to our advantage to pilot this as well. So we did get a lot more measures, but I only had 13 pairs of measures, so people that completed the pre and post measures to compare. The average age of the participant of the 13 sets that I got was 79 years old. So for people that aren't familiar with the FESI or the Falls Efficacy Scale, the minimum score is 16. So someone that has no concern of falling would score a 16. And someone who's very, very concerned, the maximum score you can get is a 64. So our average scores at pre-measures were 37 and at post-measures were 32. Yes, they still come up in the high concern range, but there was an improvement, which is good to see. I mean, the program is aimed at people who have had a fall or have had a fear of falling. So we would expect higher scores. But we thought to get more information, let's break it down a bit. So we looked at the average question score. So in the pre-measures, out of 4, the average score was 2.3. So that brings the person between kind of somewhat concerned and barely concerned. What was interesting is the most highly rated score was walking on uneven surfaces and walking on a slippery surface. And that was about half of the participants that had a fear of falling during these activities, which I'll speak to a little bit in a second. And then on the post measures, our average question score had reduced to 1.9, which is great. And that is somewhere between no concern and somewhat concerned, if 2 was somewhat concerned of having a fall. The previously most rated items of walking on an uneven surface and a slippery surface did reduce. They didn't even come up as the most highly rated item. Interestingly, walking around the neighbourhood did, but at only 15%. So that's looking at 1 to 2 participants. And a discussion among the team, we wondered if, we have a guest speaker that came the week before to talk about pedestrian safety in the council. So maybe it was more front of mind when they were doing the measure. Then in the Promise 29, so this is your quality of life outcome measure. Again, just the same 13 pairs. This data is a lot richer and a bit harder to explain in one slide, but I'll do my best, so bear with me. In the Promise 29, there's 7 different domains, and you break it down into 2, which is a physical domain and a symptom domain. So they're on the right there, physical and symptom. A higher score in a symptom domain equals higher symptoms, so not good. A higher score in a physical domain indicates a higher function or a higher ability, so that is good. So at pre and post kind of comparisons, we saw that people did improve in all the physical domains, which is really good. It's probably where a lot of the program is aimed at. And in the symptom domains, we saw some improvement in anxiety and pain. We didn't see any improvement in depression, fatigue and sleep, but they all kind of fell within, our mean or one standard deviation of the mean. So not a lot of significance, but when we have more data, that would be something we can definitely look into. So how did we use the data? We reviewed it after week 1 and then we shared it with group facilitators so that they could adjust their programming a little bit to the needs of the group. So as I mentioned in the BESI, we found out that people walking on slippery surfaces and uneven surfaces were their higher fears. So we were able to, when we were doing the strength and balance exercises, directly relate it to how that would help them in these situations. We were able to take them outside and try them on uneven surfaces. And then, for instance, in the quality of life measure, we saw that doing chores was something that people had a concern about. So there's a guest speaker that's an occupational therapist and can talk about reducing people's falls risk when doing chores. And the other thing we did to use the data was, as part of the Stepping On program, you have your 3-month booster group, and we made sure that we compared the data and fed back to the group as a whole in that booster session. So what we've learned, older people were very open to using iPads. I could not get people to do the paper forms. They wanted to wait for the iPads. So don't let that be a barrier to you. I personally really enjoyed having outcomes from other components of the program than the strength and balance measures. It was nice to see a huge part of the program is the education. So it's nice to see that what we're doing there can make a difference as well. We did need a little bit of extra help to get the measures done. So that was a big learning. And also that you need time to review the measures, theme them and document them. And here's a few thoughts for what we'll do next. So we're just going to try completing the measures a little bit earlier to give us a bit more time for adequate feedback and give people the opportunity to have one-on-one feedback. As mentioned, the tool's really helpful at sharing with GPs or other service providers. So we want to make sure we're sharing the outcomes and feeding back to them. We're going to offer time for individual feedback from their reported measures in the follow-up phone calls or home assessments. That's already part of the Stepping On program. And that is it. Thank you.
Congratulations. That sounds like a very rich experience with lots of learning. So thank you. Unfortunately, we don't have much time for questions, but I'm sure if anyone has any questions of the team, they can come up to you afterwards. So thank you very much.
Thank you.
I'd like to introduce you now to Liz Mason and Elham Almasi. Would you like to come forward, Liz? Thank you. So a little bit about Liz. She's married to Luke. He's spunk, Luke. He sounds like a spunk, yeah. She has an 18-year-old son. You don't look nearly old enough to have an 18-year-old son. And a dog named Tex, cool name. She's worked in health for over 20 years, started nursing, enjoying a variety of roles, including frontline nursing and management, strategic development, redesign and innovation, and currently clinical governance. She's passionate about improvement and working with staff to increase their knowledge and skills in this area, to develop leaders to make a difference to the safety of our patients. She's led local, district and statewide projects and loves the learning that comes from them to take into the next and into this dynamic and ever-changing healthcare system. Well done. Her fun fact is, it may surprise people that she gets road rage. Liz. And we'll introduce you to Elham. Elham is the aged care CNC at Sutherland. Elham has a master's in gerontology and a master's degree in public health. Very impressive. She has a passion for patient safety and has led a number of patient safety initiatives at Sutherland over the last few years. She's the clinical lead for the development of the Sutherland Hospital Falls Prevention and Management Portal, and currently leading the Falls Prevention Project at one of the aged care wards in Sutherland. And your fun fact is that you enjoy physical challenge of lifting weights and getting stronger, and your dream is to take part in a female bodybuilding competition when you reach your 70s. Whoa. Thank you. Over to you.
Thanks, Jane. Can everyone hear me all right? My fun fact, I'm not that proud of it, actually. It's probably not fun, but for those of you that know me, it's sort of quite contrast to my personality. I am normally a calm person, but I do try and tone it down when I have someone in the car with me and just try and sing along to the radio or something. So Elham and I are going to give you or share with you a piece of work that we've been focusing on at Southern Hospital since about mid last year to reduce our harm from falls for patients admitted to hospital. So we'll give you a bit of an overview of our driver for change, how we've gone about it, what we've put in place, and some results that we've got as at the end of December last year. So I'm just going to start with a bit of a patient story. It is a persona, so it's sort of it captures a typical sort of journey of patients that we deal with at Sutherland Hospital. So this is Audrey. Audrey's 87. She lives at home with her son. She presented to the emergency department with cellulitis, reduced mobility, a delirium, and she had about 6 days of intravenous antibiotics and was then cleared medically and was awaiting placement to a residential aged care facility. While she was in hospital, she had an unwitnessed fall. She was in the bathroom on her own and she was trying to pull up the pull-ups that she had in place for her new incontinence since she'd been admitted to hospital. And she had a fall and fractured her hip. So she did go and have some surgery. She had a right hip hemiarthroplasty. And unfortunately for Audrey, she deteriorated post-operatively and she continued to deteriorate and sadly she died. Obviously something that's very devastating for the family and the people around her and that loved her. And whilst I'd like to say that this is a sort of one-off for patients that come into hospital, but it's not. We see this way too often, and we actually started to see a bit of a trend in harm from falls at Sutherland Hospital. So we thought we actually need to change the way we're sort of doing things, and wanted to do something about it. We had a look at some data, some baseline data from a 12-month period going back to May 2021. And in that analysis, with this table on the left there, 8 out of 12 months someone had been harmed from having a fall in hospital. Either they died from having a fall or sustained major harm from a fall. So therefore, only 4 out of the 12 months, no one had been harmed. So that really set our driver for change and the need to do something about it and fix it and improve things for patients. Our graph on the right there, whilst you can see that interestingly our falls rate from May 2021 was trending down, the important part, and what I've already alluded to and pointed out, is our harm from falls was trending up. So the red dotted line, importantly, that's our harm score 1, so people dying from having a fall, was trending up, as was our harm score 2s, which is patients sustaining major harm from a fall. They were both trending up together. So we had, unfortunately, 3 patients die from a fall over that 12-month period, and 13 patients had sustained major harm from having a fall whilst in hospital. So we put in place a working party and we gave ourselves an aim of wanting to achieve 50% reduction in harm from falls by the end of April this year. We did go through a point where we thought, that's a bit aspirational, but you'll see how we're going when Elham gives you a sense of how we're actually tracking towards that. So what that looked like was we wanted to have less than 8 patients have either died from a fall or sustained major harm from a fall by the end of April this year. So the approach we took was we put our monthly falls committee meeting on hold, and I was the chair of that committee and I actually felt really uncomfortable doing that because we'd been having a monthly falls committee meeting for years. But we established a working party with fewer people and only focusing on 4 wards that were in scope for the project. Our executive sponsors were our Director of Medical Services for Sutherland Hospital and the Director of Nursing and Midwifery, and they really have done a fantastic job and continue to in help set the scene and create that urgency for change and the need to really work to reduce our harm from falls for patients. So we gave each ward in scope. So we had Bacala and Kalara Acute. They are our aged care wards. And Gunya is a medical oncology and neurology ward, and Warrada is a respiratory ward. We gave those 4 wards permission to go away and work with their staff analyse their own data, collect and analyse their own baseline data to really understand what their issues, barriers, challenges were, and together come up with ideas that they can actually test to help not only reduce their falls rate, but importantly reduce the harm from falls that their patients were sustaining. We were meeting fortnightly and we continue to do that. That really helps with the momentum and keep things going, and our executive sponsors attend when they can. The quality improvement approach we took was that of improvement science, so the model for improvement, that was data-driven, clinician-led and person-centred. So there was strong engagement from all staff across each of the 4 wards that were in scope, and then we were hearing and capturing the voice of patients and their families as well as part of that baseline data collection. And there was coaching and support provided from my team, the clinical governance unit at Sutherland Hospital. From an organisational point of view, we were capturing our baseline data as well and really looked at the themes that were coming from the data that was collected and analysed at the wards that were in scope. And what we found was there was a real challenge to provide of staff to be able to provide adequate supervision for patients, and things that were contributing to that were reduced staffing vacancies. A lot of staff were off over sort of the winter period and up to sort of, November last year. They'd had COVID. There was a lot of staff working overtime. We weren't reaching our nursing hours per patient day hours. And even a lot of COVID positive patients that were in single rooms. Our single rooms were often in some of our wards away from the nurses' station, and at the end of the ward. The donning and doffing for COVID patients made it sort of problematic for staff to get into, to be with the patients quickly. And then we'd noticed some themes around patient confusion and delirium. We've heard a lot about that already today. And then some themes around anticoagulation. We have sort of falls that we looked at, we'd noticed that patients have been anticoagulated. We've sort of parked that a little bit and focused sort of on other things for now. So what we did from an organisational point of view, so the wards in scope have gone off and done specific and tested specific ideas for the area that works for them. But from an organisational point of view, we really increased awareness of falls prevention and management. We send out a monthly fall fact bulletin that contains key facts about falls specific to Sutherland Hospital. And we presented at some of our peak meetings as well, such as the Clinical Council, the Nursing Midwifery Practice meeting and the Nursing Leadership and Quality meeting, and of course our peak Patient Safety and Quality Committee as well. I was updating our executive regularly at our weekly huddles, and the NUMs of each of the 4 wards in scope have done a really good job at reinforcing the improvements for their own areas, talking about it constantly at their team meetings, their patient safety meetings, using their safety and quality boards to really showcase and highlight that we are doing this piece of work to reduce harm from falls for our patients that are admitted there. So I'm going to hand over to Elham, who's going to take you through specifically what some of the wards actually put in place, and then how we're tracking and going with our results as at the end of December last year. Do you want to
hello everyone. So let's look at some of those interventions that each ward implemented. As Liz mentioned, there were 4 wards in scope. Bakala is one of our aged care wards, and they focused on increasing supervision. So increasing supervision at the bedside, increasing supervision in the high-risk observation room, and also increasing supervision during toileting. So on this particular ward, the staff were undertaking tasks and documentation at the bedside. And also some of the other strategies included laminating the page numbers and the phone numbers and placing those important numbers under medication trolleys and encouraging the nursing staff to use the portable phone rather than leaving the bedside. So all those are small steps to encourage increased supervision at the bedside. Next ward is Ganya, which is our medical oncology and also neurology. Shortly after the start of the project, this ward was selected to participate in the Accelerate Plus program. However, the strategies in the Accelerate Plus program were aligned with the Falls project. So they continue to focus on bedside clinical handover with patient involvement and also improving doing risk assessment and also FRAMP for their patients. Next ward is Kalara Acute, which is also another aged care ward at Sutherland. This ward also look after patients with severe dementia and BPSD. Their focus been on safe mobilization, and as you heard in the morning session from Ashley and Claire, safe mobilization and early mobilization being the focus for this ward. And the staff received education about the Give It a Go guideline. They also wanted to increase supervision at the bedside. And some of the strategies that they used was including, for example, the pharmacist to assist the nursing staff to restock their medication trolleys each shift so they don't have to leave the bedside and go to the treatment room. And last but not least, Waroda, which is our respiratory ward. Waroda focused on improving their communication about patients' falls risk, but also they wanted to implement a process to flag post-fall huddles to the NUM and to the nurse in charge, and also review the post-fall huddle forms with their allied health team to ensure correct aids are in place for the patient. So let's look at some of our pre and post implementation data. So the graph on the top on the left-hand side showing the falls rate and also the harm as a result of falls at Sutherland Hospital from November 21 to May 2022. And as you can see, unfortunately, we had 13, total of 13 harm score 1 and 2 during that period. Since the start of the project, we have seen a slight improvement in the number in falls rate and in the number of falls, but more importantly, we had 54% reduction in harm score 1 and 2. There hasn't been any harm from the falls in the months of June, July, September, and November. And this is in the context of severe or significant staffing challenges that we have had during those months. For the 4 wards in a scope, they had overall 44% reduction in harm, and our aim being 50% reduction in harm by April this year. We think that we are on track to achieve that goal. I just want to briefly mention or go through some of the data for each individual ward. So Bakala, they had since November 21 to May 2022, so their falls rate were going up, and they were also having harms as a result of falls. And since the start of the project, they have seen 50% reduction in harm. They have had reduction in the number of falls in the high-risk observation room, and also they had a reduction in the number of falls which occurred in the bathroom. Interestingly, we have noticed 43% of their falls happen in single rooms, and review of those data showed that the majority of those patients needed to be in isolation because of the COVID. So that has remained, unfortunately, an ongoing challenge for this particular ward. Next ward, Ganya. So even though we haven't seen major improvement in terms of falls rate, Ghana been they have reduced their harm by 50%, which is a very positive result, I think, for this ward. So Clara Acute, out of the 4 wards in a scope, Clara Acute has been challenged the most with significant staffing, meaning staffing vacancies, and also due to the nature of their patients. Even though we haven't seen any reduction in harm yet, there has been a specific measures, there have been improvement in specific measures, such as reduction in the number of unwitnessed falls, and also slight reduction in the number of falls in bathroom. And last Warada, that they have seen major improvement both in terms of falls rate and also harm, which shows that their strategies in terms of communication has been working well, and they have been able to sustain that improvement. Next step.
Okay, so our next steps are to continue with the approach that we've put in place, which we think is working. And each ward is doing, a really good job at continuing to look at their data and communicate with their staff to implement and sustain the ideas that they want to test. And actually most of them are, because they're seeing improvement of the ideas that they've tested, they're actually implementing those ideas instead of just being in that testing phase. We want to bring more wards on that will be in scope for those wards that we know are also trending up in their falls rate as well. And we want to continue to work on unwitnessed falls and reduce falls, patients falling over in bathrooms. So as you've heard from Elham, those strategies that the wards are putting in place, they're actually working, because some of the areas have seen an improvement in unwitnessed falls. So providing that supervision, what they're doing to be able to do that is actually giving a positive result, which is excellent. And of course, we want to continue to reinforce and celebrate the progress and the positive results that those that we're getting, not only from those 4 wards in scope, but from an organisational point of view as well. And we'll obviously do that in a more formal way at the end of April this year. It's a continual work in progress, I will have to say, and that's one key learning for us. As you would know, making improvement and change is a work in progress. It's not easy and it takes time. But we are seeing positive results, which is great, and having that person-centred approach to improvement is certainly working for us. And another key learning is around challenging the wards to look at their models of care in a different way, and they've had to do this because of having challenges with staffing each shift. Clara Acute did a little bit of analysis in August last year. They looked at their staffing for each shift over the whole month of August, and there was at least one shift every 24 hours where they were down on staff. That makes it really, really challenging to provide that adequate supervision to patients. So that's what they were dealing with. And then, of course, strong sponsorship is key. Our executive sponsors are really committed to this, and they model it. And without their support, I don't think we'd have the sort of the results that we're having at the moment. So I just want to acknowledge Dr. Van Nguyen and Joe Newbury. They're our executive sponsors for the project. And of course, and importantly, our Falls Working Party members. And Bianca, I apologise, I've left you off the list. Bianca is laughing there, you know who she is now. She was involved at the beginning. She now works at Prince of Wales Hospital, so thank you for your involvement when you were working with us, Bianca. And I want to congratulate Claire and Ashley, who you heard from earlier. They've done really great work in Clara Acute, one of the wards in scope, and Bacala as well, of course, to work with nursing staff and educate them to mobilise patients early using that Give It a Go pathway, and that's having really good results, as you've heard. And I do also want to say a big thank you to Patrice Thomas, our patient safety manager at SESLHD Hospital, who's pulled all this data together. She's a whiz when it comes to data analysis, so her skill in that area is very much needed and appreciated. And obviously thank you to everyone else who's really shows a commitment and a dedication and a passion to want to make a difference in this space. Everyone, it means a lot to everyone, because the outcome that you get, is a devastating one. And we've got that driver for change that sort of helps keep everyone going. We don't want that to happen at all. And it's great that we're seeing some positive results in what is a really challenging space. Thank you.
Thank you, Liz. Thank you, Elham. Unfortunately, we don't probably have any time for questions, but I'm sure you won't mind if people reach out to you one-on-one if they have. Yeah, sorry. No, it's okay. All good. Now I'd like to introduce everyone to Professor Jacqui Close. Welcome, Jacqui. Jacqui is a consultant in orthogeriatrics at Prince of Wales and is the Clinical Director of Falls, Balance and Injury Research Centre at the Neurosciences Research Australia. Her primary research areas falls in people with cognitive impairment and dementia, and particularly the relationship of cognitive function to postural stability, falls and fractures. She also has an epidemiological interest in the impact of falls and injury to health service use and the way in which health services are designed to prevent and manage falls and injury in older people. She sits on a number of state and national committees in relation to aged care and is the co-chair of the ANZ Health Fracture Registry, chair of the ACSQHC, sorry, my apologies, Clinical Care Standards Working Group on Hip Fractures, and the president of the Australian and New Zealand Society of Geriatric Medicine. Thank you, Jacqui.
Thank you very much. Apologies, I didn't send a fun fact.
Oh, yes. What's your fun fact, Jacqui?
I've just got a new puppy.
Oh!
He's an absolute delight, not a disaster, delight. But he's also high maintenance, but he's gorgeous. He's gorgeous. All right. So in 20, 25 minutes, I'm just going to take you through some of the evidence in falls prevention, but trying to keep it reasonably practical if I'm able. So the reality is, where is the evidence? Where does the evidence sit? If you really wanted to know what works in what setting, you turn to these turgid tomes of 400-500 pages full of forest plots and statistics, etc., and presented in a way that is not terribly user-friendly, accurate from a statistical perspective, but very difficult to interpret. But the bottom line there is a lot of evidence out there that tells us how we can prevent falls in an older population, in the community, in the hospital setting less so, but also in residential aged care. So the last time the Cochrane collaboration updates for falls occurred was around 2018-19, but they're continually updated. I'm not sure whether you're aware of this document. This is 36 pages, so shorter, that was published in Age and Ageing last year. So these are the world guidelines for falls prevention. They produce a series of recommendations, and there are a number of us from Australia that were involved in the production of these guidelines. I'm not going to go through them all today. They're easily accessible via the internet. What I will focus on, though, which I think is probably the most useful component of the document, is actually the clinical algorithm that takes you down a number of different paths based on your level of risk. And you basically enter either through opportunistic case finding, that's usually in the primary care setting, not necessarily entirely, or if you've come to a healthcare setting with a fall or fall-related injury. So we just focus down the left-hand side. So these are the lower risk or low risk population. Nobody's no risk. Low risk population. So these are people who perhaps have said that they've had a fall in the last year or haven't had a fall in the last year, have had a fall in the last year, but they didn't sustain any injuries. They're not multiple fallers. They're not frail. They were able to get off the floor and there's nothing to suggest a sinkable type event. They've got no significant gait or balance impairment, a couple of tests there that you can do, including in primary care. These are the low risk population. Now, low risk does not mean to say we do nothing. We don't necessarily do anything from a healthcare perspective in terms of delivering interventions, but we absolutely, from a public and population health perspective, should be encouraging people to undertake exercise. There are many, many reasons to exercise. Falls prevention is just one of them. So this is just the WHO guidelines for physical activity, including older adults. And our older adults should be doing anywhere between 150 and 300 minutes of moderate intensity exercise per week. A couple of days a week, you should be incorporating some strength training, 2 or 3 days a week incorporating some balance training. So that multimodal approach to exercise that people can do in their own home environment, go to the local gyms, etc. Health does not necessarily need to pay for getting these people through interventions, but we very definitely should be promoting exercise. Likewise, the Australian government has produced some guidelines around, again, older people, encouraging older people, this time it's 65 years and older, in terms of doing exercise, the need to do moderate exercise. Interesting to see, where is it? Somewhere there is flexibility, was vacuuming. Oh yeah, mopping and vacuuming. So anybody that doesn't enjoy mopping and vacuuming, it's exercise. Tai Chi's down there in flexibility. I'd argue that Tai Chi is probably one of the best balance training exercises that people can do. But there's guidelines out there that tell us what we should be doing in relation to physical activity. The next group are that sort of middle group. So those individuals who may have had a fall in the last month, no significant injuries, not a multiple fall or not frail, but gait speed reduced or timed up and go greater than 15 seconds. They're relatively arbitrary cut points, but you need cut points to get people down different pathways. This is probably the group where we should be recommending tailored exercise. Very definitely focusing on falls prevention with exercise that targets strength and balance. They can still do other exercise, but we want to get them to do strength and balance training exercises. And there's a wealth of literature out there that tells us that exercise as a single modality is effective in relation to reducing falls and fall-related fractures. So this is a synthesis of what the Cochrane review says. Exercise reduces the rate of falls by about 23%. It reduces the number of people who fall one or more times, and it probably reduces your chances of a fall-related fracture. So the evidence out there is strong for exercise. But it can't be any old exercise. You can't sit in a chair with a couple of TheraBands waving your hands in the air. That does not prevent falls. We've looked at previous systematic reviews in relation to falls prevention, and this is one of Kathy Sherrington's papers. It's old now, but the information from it is the exact same. If you do not have sufficient balance training in your exercise program and you're marketing it to prevent falls, you will not prevent falls. There has to be a moderate to high challenge to balance. This is an interesting one. The general population are more likely to benefit from a fall or an exercise for fall prevention than a high-risk population. So the high-risk populations might be people who've had strokes, other chronic conditions, Parkinson's disease, cognitive impairment. That's not to say they won't benefit, but the main benefits seem to be in a general population. And it might well be that that high-risk population needs a little bit more than just exercise. And surprise, surprise, you have to do the exercise. You don't just sign up to saying you're going to do it. You actually have to do it. And that pretty much equates to about 150 minutes of exercise per week. So in southeast Sydney, and in fact across the whole of the state, we have Stepping On. Stepping On is not an exercise program to prevent falls. It is way more than that. It doesn't sell itself as an exercise program, and the amount of exercise in Stepping On is not sufficient to prevent falls. But there is way more to Stepping On in terms of the educational component, the self-efficacy and component to it as well. So Stepping On is an effective intervention strategy to prevent falls, but it is not just an exercise intervention. And for most of us referring people into stepping on, the expectation is they complete the stepping on program, but they carry on then exercising longer term. Over on the right, this is the higher risk population. So these are people who have fallen, presented to healthcare, maybe with an injury as a result of that fall, who've fallen more than once in the last year, who are frail, who haven't been able to get off the ground as a result of a fall, or you're suspecting some sort of syncopal event, which is a relatively small proportion of the people that we see. They're the ones that probably need a referral to a falls clinic or a more comprehensive, multifaceted assessment. So when we talk about frailty, I mean, we use the word frailty a lot, but it's that impaired ability to withstand a physiological insult. So on the right here, we've got Boeing's Dreamliner, which regularly goes across the Pacific. Here's Sir Charles Kingsford Smith's Southern Cross. It also managed to get across the Pacific. But if the two of those planes took off and they encountered a storm, the chances are the Boeing will sail through and we may not see the Southern Cross make it across the Pacific. There is inbuilt redundancy in the Boeing Dreamliner. It can lose an engine and it will not come out of the sky. It is not frail. This is where the frailty is. So it's that ability to withstand a physiological insult, whether that's intrinsic or extrinsic. Most of us use the clinical frailty scale. It's available in the EMR system across our district. And when we're looking for people who are frail, these are the mildly frail with issues with their higher order ADLs, domestic type activities, right the way up to the terminally ill. In fact, the person who's very severely frail looks sicker than this person, but actually this is a relative sitting by the bedside. So just a warning in terms of exercise. So this is an exercise, a randomized control trial we undertook, which included this particular district, and it was about exercise in people being discharged home from hospital, and it was from the rehabilitation and orthopaedic wards at Royal North Shore, Prince of Wales, War Memorial, and Greenwich. And we did the standard type exercises that incorporated both balance and strength training, so everything that the literature tells us to do. And the reality is we increased the risk of falls. I would argue that this population, and we probably need to go back and look at this population again, I suspect that this population is a predominantly frail population, that the exercise on its own is probably insufficient to prevent falls in this particular population. Either the exercise is not sufficient in terms of intensity, duration, or progression, or they need the additional components, which might be the OT component of it or the medical component of an intervention. So those people going down that right-hand side of the algorithm who need that sort of more multifaceted approach, we very definitely should be looking at medications, avoiding medications that potentially increase your risk of falls. They are predominantly centrally acting medications. Where people have got cataracts, we should be advocating for early cataract extraction. There are particular benefits with removal of the first cataract. Some people will need both cataracts removed, if that's the case, but certainly you will get benefits in relation to falls prevention from early cataract extraction. Multifocal glasses. Multifocal glasses are a risk factor for falls. If you are a regular outdoor ambulator, then removing those glasses and using 2 pairs of single lens glasses, one for distance, one for reading, is the correct advice to give. You just need to be careful who you're giving the advice to. That's very difficult. If you've got somebody with you who has dementia, telling them to use 2 different sets of glasses actually may be problematic. So you need to be able to synthesize the evidence, but then apply it in a pragmatic way in clinical practice. Likewise, evidence for OT home assessment. We shouldn't be doing OT home assessments in absolutely everybody, but the higher risk end of the spectrum would benefit from an occupational therapist interacting with the patient, watching how they work, how they navigate their own environment, and trying to make that environment safer. There's evidence for good footwear and good foot care. Down the bottom left, sorry, for be sexist making the comment, but many females would not consider this to be aesthetically pleasing as a shoe, but it is actually the safest shoe. So it's a thin, solid, a hard sole with lace-ups over the midfoot, and then around the ankle, a high collar to support the foot. The residential aged care and hospitals. So again, there is evidence in residential aged care and hospitals, and let's cover them briefly. So residential aged care, what does Cochrane say at this particular point in time? It is on the fence as to whether there is benefit of exercise as a single modality for preventing falls. Now, when that came out subsequent to the Cochrane, there's been the Sunbeam trial, which did reduce falls. The Sunbeam trial involves a lot of machinery in terms of doing strength and balance training, but it was from Australia and did provide some evidence of benefit. But on the whole, exercise as a single modality is probably not where you put your money in residential aged care. There is relatively little evidence that doing a general medication review will make any difference to your rate of falls. There are other reasons why you would review people's medications, but there's probably little point in selling it as a falls prevention strategy. Where your evidence really is, there is moderate quality evidence of vitamin D supplementation. If you did nothing else tomorrow, if you work in residential aged care, if you did nothing else tomorrow, you should have everybody on vitamin D. And unless there is some sort of contraindication, which very few people would have, if you handed out vitamin D, you would reduce the rate of falls in residential aged care. To be perfectly honest, I think over the years we are seeing more and more people in residential aged care now routinely put on vitamin D, but the evidence is there to support it. And again, limited evidence around the multifactorial approach to falls prevention. So these are a really hard group of individuals in terms of trying to prevent falls. So if you do the gold bar type approach, like I said, if you did nothing else, you would be going down the route of vitamin D in residential aged care. And you can give vitamin D in different forms. We're used to the gel capsules up on the top left, but where you have to give people bigger doses, the Osta D liquid, so 1 ml is 5,000 international units. You can give it easily, particularly for people who don't like swallowing tablets. And the Vita D gummies on the right, you can buy those in Coles and Woolies, delicious. Here's a paper, if you haven't read this and you have anything to do with residential aged care, this is a must. Really good paper, come in the BMJ, published late 2021. This is the first study to show the benefits of nutritional intervention in preventing falls and fractures. What was the intervention? So there's a number of facilities across Melbourne and the surrounds of Melbourne. So 60 residential aged care facilities participated in this. The intervention was targeted at increasing the calcium and protein intake in people's diets. And they did that using milk, cheese and yogurt for calcium. And then in terms of protein, it's meat, predominantly chicken, but eggs, legumes, nuts, and seeds. And they didn't add it to the existing diet. They looked at substitution because a lot of people don't eat huge amounts. So to give them all of this on top of what they were already eating wasn't going to work. And they negotiated with each of the individual facilities because, of course, everybody's approach to food in facilities is different as well. So they negotiated with each of the facilities to try and incorporate more calcium and protein into the diet. And the bottom line is it worked. Good nutrition actually works. So it significantly reduced all fractures. It significantly reduced hip fractures. It also reduced falls. The impact is probably a combination both in terms of falls prevention, but I suspect there is also a significant bone health component to this as well. But good nutrition makes a difference. How well do we invest in nutrition in residential aged care? Hospitals are so much harder. We invest so much energy, but the evidence to support what we're doing is not as robust as it would be in the community and, to a certain degree, residential aged care. So in the World Falls guidelines that have come out, we explicitly say you should not be using falls risk screening tools. Now, that doesn't mean to say the accreditation standards will suddenly come on board and say you don't have to use them. We will have to work with this over time. But screening on the whole is not an effective approach to identifying at-risk populations. What we are saying is older people coming into hospital, we should be assessing them for modifiable risks and putting in place an appropriate falls prevention plan. Education does seem to work in the hospital setting. So talking to patients who have the cognitive wherewithal to be able to process the information that you're saying to them, education works as a form of falls prevention. When I first came to this country in 2005, I was asked to give a talk about falls prevention in hospitals, and I produced this slide. It's actually stood me well over the test over time. Maybe to a lesser degree now, but certainly when I first came here, we were very definitely considering issues as siloed individual issues and really not giving sufficient consideration to the fact that falls, cognition, continence, pressure care, they are all integrally linked. And if you did nothing else in terms of falls prevention in hospitals, you probably, where you're most likely to be successful, is make sure that you have an adequately skilled, trained nursing workforce, allied health and medicine as well, who are able to manage people who are cognitively impaired, be that a dementia or a delirium, because that's where a significant amount of our falls and fall-related injuries occur. But there's lots of things around continence. So 45% of our falls occur because people are going to the toilet. Managing continence proactively, lots of opportunity to do things differently. Medication, yes, nutrition, of course. So my own personal view in falls prevention in the hospital setting is very much focused on how do we best manage our population who are cognitively impaired or delirious. And there's lots of things you could do in terms of nutrition, hydration, ensuring pain is adequately addressed, making sure that they can actually see where they are, date, time, glasses, hearing aids, bowel care, bladder care, what we would consider essential care. That's really important in terms of brain care. I'm just going to finish in a couple of slides. Please don't forget the bone. So I know today is very much around the falls side of things, but actually there is a wealth of evidence out there that tells us that we can prevent fractures, both through a falls prevention pathway, but also by making sure that people who have sustained a low trauma fracture, that they are offered treatment for osteoporosis and that they stay on the treatment for osteoporosis. So here's an example. This is from the Hip Fracture Registry report that was out in September of last year. It shows you the proportion. Don't try and read where the hospital, don't try and read the columns there. I've showed you where the hospitals are. These are the percentage of patients, and you want to be in the dark, you want to be the dark blue lines. These are the percentage of patients who have come into hospital with a hip fracture, who leave hospital on treatment for osteoporosis. Now, it's never going to be 100%. There are some people who are clearly at the end of life and it's not appropriate. There are some where we struggle to get vitamin D levels sufficient to be able to initiate treatment. But I would argue that those figures are not good. They are not good enough. Yes, Prince of Wales is up there higher than St George and Sutherland, but actually it's not good enough for Prince of Wales. Even the ones up the top are not good enough. There is scope for improvement across this district. We've got evidence out there that interventions are effective. Doctors are fully aware of the evidence. It is part of their treatment. I can see Peter Smerdley here. He teaches medical students about osteoporosis. They come out of medical school knowing. The treatments are relatively inexpensive. When we compare what we spend on some of the cancer drugs, thousands upon thousands of dollars, the most expensive treatment we have is probably denosumab, which is about $300 a shot. Yet there's a hoo-ha about prescribing it. So why doesn't it routinely happen? Like, who owns the bone? And I think that lack of accountability is part of the problem. Public and patient awareness. people read things in the Sydney Morning Herald, read about osteonecrosis of the jaw, atypical fractures, rather than potentially the benefits of taking medications. Our systems of care are undoubtedly fragmented. There's lots of arguments. So the state Commonwealth agreement for New South Wales doesn't work for this particular model. The states will argue that the osteoporosis is a chronic disease and therefore the Commonwealth should cover it. But actually the reality is the fractures come to hospital, the states pay for the cost of the consequences of osteoporosis. And to a certain degree, professional organisations haven't always worked collaboratively in terms of highlighting this as an issue. So I'm going to stop by saying there is evidence out there that we can prevent falls. It's not terribly well packaged for those of us practicing on the front line. We need to consider falls prevention, but in the bigger picture for older people, people don't get up in the morning and worry about falls. They worry about remaining independent, staying at home, not being in pain, being able to stay connected with family and community. So we need to just build in falls prevention into the bigger picture. From a public health perspective, who invests and pays for getting more and more older people to be exercising routinely as part of getting older, and what's the role of the private health insurers? Community medium risk individuals very definitely should be going down an exercise pathway. High risk down the falls clinic type approach, doesn't have to be in a hospital. For residential aged care, vitamin D and feed them good food, calcium and protein, and hospitals engage and educate patients around safe mobility. I think that's been highlighted already today, and focus on high quality brain care in hospitals. Thank you.
Thank you, Jacqui. Very comprehensive unpacking of that Cochrane evidence. Thank you very much. I'd like to invite you now to join our panel, invite our other panel members to come forward. So we're bringing forward again Lorraine and Libby, and we're welcoming down Danielle and Karen to join the panel. Yes, please. So we're going to be sharing a microphone. Sorry, that's a little bit cumbersome.
There we go. We're good. We just had to shift our view to the stage so our lovely viewers online could see everyone. Is that a little better? Fantastic. All right, looks like I'm standing for our panel session today, so apologies for that. No, not at all. It's good for me to get up and move. All the evidence today. I might stand on one leg, perhaps. Could do that, couldn't I? Challenge myself. So, good afternoon, welcome. This is the panel section of today's program, and unfortunately we only have 15 minutes with our panel members today, which is such a shame because I feel like we could spend days here with them, picking their brains and learning as much as we possibly can from their experience. So what I might do is just, for those who have joined us virtually and in the room and may not have been here all day, if we could just get each of our panel members just to say who you are and where you're from, and then we might launch into a couple of really curious questions that have been put forward by our audience members today. How does that sound? Great.
Jacqui Close, geriatrician, Prince of Wales.
Karen Tuqiri, Director of Nursing, Prince of Wales.
Lorraine Lovitt, Older Persons Patient Safety Program, CEC.
Danielle Treacy, Physiotherapy Advisor.
Libby Powell, Health Equity, Promotion and Prevention.
Wonderful. We might leave the microphone down there, Libby, because I think I'm going to head to you first and pick up on one of the common themes that has come through from today, and that's really around equity and access for our community members, our very diverse community members. So I was hoping you might be able to unpack that a bit more and share that for us in the construct and realm of health promotion services and the work that you do across the district.
Yeah, sure. In my presentation, I did say that we know we're not doing enough and we know we're not reaching priority populations. But what we are trying to do is collaborate with services both internally and externally to our organisation to reach people that need these programmes and services the most. We have colleagues here today. I know we've got Natalie Narunsky in the crowd from our older people's mental health service. And we've been working with Natalie and her team at Prince of Wales, and then more recently at the Sutherland Hospital in St George, to engage consumers in the Stepping On programme. And the other example is working with our HARP team, who've identified individuals who are living with HIV. And I think the reason those programs have worked, we haven't actually tailored the Stepping On program, but the setting in which we've delivered has been a setting that's familiar. They feel safe and welcomed. It's within a trauma-informed environment, and the staff have actually been trained as Stepping On facilitators. So that's just one example. But as I said, I know we can do more, and it might be that we go back to the drawing board and actually these state-funded programs aren't the silver bullet for everybody, and it's about co-designing and co-producing something that works for these target communities.
Thanks, Livia. I like that idea of co-design and rather doing to or doing on, doing with. What do you see as the opportunities for us, this is to all of our panel members within our system, to improve how we co-design service or how we support our staff to understand co-design in order to provide equity and access to services?
Well, I think we're learning a lot from what's happening on the front line. So I think maybe I will pass the mic on because it's just sort of, sometimes it's the anecdotal that is very powerful for us as opposed to the data that's published. So I don't know if anyone wants to talk to what they're seeing and hearing in the day-to-day work.
Anyone?
The co-design approach absolutely is the way we need to be going. I would just add some caution there. So if I take exercise as an example, we do need to stick to what the evidence says we need to do, which is strength and balance. How we choose to do it, we absolutely should be informed by our consumers as to how we best deliver an exercise program that still sticks to the underlying principles that the exercise that they do, however they choose to do it, wherever they choose to do it, still incorporates the right components. But at the end of the day, none of these interventions work unless people actually do them. So if we can't be bothered to co-design with our consumers, we are unlikely to reap the benefits of falls prevention interventions. So I agree, co-design is the way forward. I don't think we spend enough time doing it. It's even hard, well, it's hard in a hospital setting. Everything is protocolized. I think that our cold populations struggle in an environment where English is the language of choice. We do have access to interpreters, but I think it is very difficult to deliver high quality, equitable care to other populations. And culture, I don't think we understand culture well enough. We live in a very diverse area, which is something we should celebrate, but understanding the cultural aspects of how best to deliver care, and that includes to our Indigenous population as well. I think we've got a lot more education still needed.
Thanks, Jacqui. I think that's a really important point. And just on that same vein about how we're transitioning from that acute to that community setting, perhaps looking at access, looking at what gaps or pathways may need to be revisited, or what are the gaps I'm really interested, Danielle, I know this is a bit of an interest area for you, and really keen to hear a bit more from you around what some of those gaps are and what are some of the opportunities, I suppose, to support clinicians and consumers on their transition across their patient journey.
Yeah, thanks, Dan. And I think we're probably all aware that there is that imbalance between what our resources are and what the need is out in the community. So we do need to look at how we're doing things differently. And I think one of the things that we probably need to be better at, and I think, Jacqui, you sort of mentioned it, was around promoting physical activity. I think if you think all the different touch points that we see patients quite often will come in for one thing. So it might be for a geriatrician appointment, it might be for a physio outpatient appointment for a knee injury. It might be something around community health or other allied health interventions. Correct, they're not necessarily for falls prevention needs, but there's so many opportunities which we can promote physical activity, which we can encourage the benefits of exercise, proper interventions. I think that's probably a particular area that would be good to look at as well. I think there's a bit of work that Lisa Harvey's been doing around with the reform trial, which is looking at almost turning things around in that. I think we've got big wait lists. Our typical model of care is that you see one person, you complete your intervention, and then you move on to the next one. Where theirs is a bit more, you get people through the front door, you provide them a program, and then you sort of monitor them as they go through. And I think that'll be an interesting space to see if that's an effective way of expanding your resource providement, and whether that's an effective way of providing people care, I guess, while they're effectively would normally be waiting for services.
And I think that's a really important point, is to think about, has the way we've always delivered service, is it the best way to continue, and what are the things that we need to change? And I think just picking up on that, one of the key themes that have come out of today is around that focus on that person-centred care and that model of comprehensive care. And Jacqui, I'm going to steal that vision and slide around comprehensive care, if we may. I think it's an absolutely wonderful visual of how all of those different aspects of comprehensive care come together across the patient journey. I'd love to throw to Karen from Prince of Wales Hospital to talk to us a little bit about how you're looking at comprehensive care more broadly at Prince of Wales, and then some of the key elements that sit within that and how you're embedding that.
Thanks, Dan. So I guess we've been on a bit of a journey for 3 years, really making sense of comprehensive care. And I always remember one of the first meetings I had when I came into post, Jacqui came and spoke to me about a number of things, but she said to me, Karen, if you want to fix the falls issue we have here, then we need to get the JMOs and the nurses in the same room and have education about delirium and the whole person. And those words have really stuck with me since 2019. And I was given the task of leading the comprehensive care standard 5 for Prince of Wales and Sydney Eye Hospital. And so for 3 years, we've really started to reshape and invest in conversations and creating spaces where multidisciplinary leads can come together and look at the whole person. And what sits at the heart of comprehensive care is person-centred practice. It is about the whole person. It's not just about the fall or the incontinence or the challenging behaviour. It's about what's happening for that person in entirety. So we have set up a governance structure which has a comprehensive care committee that has multidisciplinary leads of all of the different levels of harm within Standard 5, where we come together and we actually sit and talk about all the different programs of work that we believe are required, but it's data-driven conversations. So we've developed a comprehensive care dashboard, which we have available for our leads to access, where we can start a conversation. It doesn't tell us the whole picture. We often have to go away and dig a little bit deeper. But a really important step for us 3 years ago was getting some meaningful data back where it needs to be with the clinicians, and then work with them around the solutions around where they see the improvement activities need to be focused. And some of the work has been, we haven't always made positive steps. We've sort of just plateaued a bit, and then other work has just taken off and really been sustained. I guess what sits at that is education. And so we have developed a multidisciplinary education session that follows a variety of patient journeys where multidisciplinary teams come into a space and work with the patient journey over 40 minutes. And as a team of medical, allied health and nursing staff, they actually work through how they are going to provide care and develop a care plan and management plan for the patient and family. And each are recognising that they all have a role in the comprehensive care plan. And so that has been going now for 12 months. We've had a couple of hundred staff come through that program, and up the back here is Carly, who is our comprehensive care CNC, who has been phenomenal in leading the way in setting up those sessions and exploring what does comprehensive care. One of our patient journeys is a patient that has a number of factors that put them at high risk for falls in the acute setting, and so they unpack what steps they're going to take to care for that patient and prevent harm. I think the other thing is around talking about harm, and we are really transparent around that and really use that language to understand sometimes that the systems and processes and the situations we place patients and families in are the root cause of the harm, and we need to be accountable for that. And we always see system failures, but there's also individual factors and team factors as well, which we need to explore. And within, as you all know, you all work in different teams in different clinical settings. There's cultures within different units. You can walk across a hospital and experience a different workplace culture going in and out of different units, and you pick up some of those positive elements and you pick up where things could be different. So I would just encourage that we're looking at. And I think also just to call out that person-centred practice is about all people. It's about the patient, the family, the carer and the staff, and what happens between the relationship in the providing and the receiving of care that's most important. So we've really tried. We've got a long way to go. I still feel we've got so much more to do, but it's one step forward through using education and governance and appreciating that at the heart of this is people.
Yeah. Thank you, Karen. I think that's a really great overview of the journey you've been on at Prince of Wales, and just how that engagement from leadership and what that enables, that vision can enable for staff. Lorraine, just picking up on some of Karen's points there around how we enable our clinicians to be involved in service change, service design, improvement. Sorry, I'm bumping the microphone. In improvement and hearing how it's working at Prince of Wales. From your statewide perspective, what are some of the other guiding lights or the bright spots that you're seeing appear across the state that you think are really worthwhile for people to focus on?
Good question. Because there's good work happening and sometimes we don't hear about it. Yeah. I am going to talk about a specific LHD, Southwestern Sydney, who has worked very hard to embrace quality improvement and training health professionals, as I talked about earlier, how we train within an LHD around quality improvement. We develop the skills within our clinical governance and elsewhere. And then we actually have leads that then help to support and drive quality improvement initiatives at a ward level. And it started with getting some extra funding through NAMO, I have to say. And so we've got further work to do there to get 2 people that supported the quality improvement initiatives with coaching. And I think actually when we start on this journey, we start talking about QI and what does that mean? People panic and they think, oh God, it's some extra work and how are we going to fit it in? But when we stop and sit and work with our frontline clinicians and get them to start talking about the challenges, and as you know, I've presented our comprehensive care model, which I might say, Jacqui, was based on that early diagram you provided to me many, many years ago. And Dan, we put that slide in before I present the model next time, I've decided. I think when we start talking with the staff and asking them which bits you're doing well, which aren't you doing well, how do we go about developing a program now to drive some improvement work? What does that mean? But we give them the tools and support them. And we've found where we can support coaching, that we're with the ward, on the team, and my colleagues that I work with, Ingrid and Marie, we're coaching different teams in different LHDs now around driving quality improvement work. And once we start that and they get it and they get the understanding of doing small bits of incremental change, plan, do, study, act cycles, if that's not working, we'll throw it out, we'll start again. And it's not around, let's develop the form and spend all our time on the form and get the form right. Let's look at the practice of care that's required and how do we go about delivering that care and what will make the difference. And we would be suggesting through the model that we've developed around comprehensive care as a starting point. So we have found when we engage with frontline staff, they begin to be involved in the conversations. They begin to be the leaders. They begin the ones that start the conversations. And I've talked to you before earlier today about ward staff, a ward clerk driving a change. So cleaners beginning to drive change. So I think it's a whole of ward. It's how we develop leaders, but we acknowledge that the leadership can actually happen from the frontline staff and enabling them to be involved in the conversation, giving them the tools, but supporting them in the process. And how do we build that capability, I think, is the biggest challenge in some ways. Yeah.
Certainly, Lorraine, I think that challenge around how do we, the permission, the cultures of permission, but also the tools for individuals to take that on and go forward with it. Karen, were you about to comment? Did I jump in? No. I think is really important. And just on that tangent, I think of how we enable our staff, one of the interesting elements is around how do we engage our clinicians in that research. So one of the things I heard you say is we don't often know about the good work being done. So I'd be keen to hear from a couple of you around how do we support and engage clinicians in that element of research, but then also the translation of that research into practice.
I'll quickly give a quick response. There are two presentations that have done today from southeastern Sydney, most definitely, that we're encouraging for an abstract to go in for our forum in May, for the Falls Forum, because we film it. It's virtual as well as face-to-face, and it'll be on the website so people can watch and encourage that. So internally, days like today, and it's giving opportunities for people to share those projects elsewhere. So we take them out of the setting where they've had some successes and we take them to another setting and we enable the conversation to happen. And that can happen internally as well. I could go on, but I think it's time to stop.
No, I think just that question there, I think it's about us paving the way and providing a pathway to make it easy for clinicians to do the work and then have opportunity to go and present it and celebrate it and acknowledge the effort that they've been working towards as a common goal as a team. And I remember a program of work when I was in the Illawarra where a CNC just had a question. She came up and asked me and she said, do you think I should turn this into a project? And I said, yeah, how can we make that happen? And just sitting with her and mapping out in half an hour, that's now her PhD, and she's exploring falls prevention from a very different perspective using appreciative inquiry and patient and staff experience around what it means post-fall, around practice change and how, that really just was a simple conversation I had, and 3 years later she's really exploring it at a new level. And I think it's our role as leaders to actually provide opportunity for these conversations, as you say, and be open to working in a research process and just breaking it down and making it as simple as possible.
Yeah. Thank you, Jacqui.
It's really just a brief comment at a higher level. I think what we are now starting to see are universities working much more collaboratively with healthcare organisations. I was at a meeting this morning, which is very much around dementia, high quality, high class dementia care. For Prince of Wales, it happens to be, but very much around what's the university going to do, what are the research opportunities, what are the training and education opportunities, and how can we ensure that our clinical services are world-class clinical services. But universities and hospitals now, you're seeing more and more of these partnerships coming together. I think it will empower more and more clinicians to do a piece of research. You do not have to do a PhD to do some research. Little small projects on the ward also make a huge amount of difference. So I think the environment is changing at a number of different levels, which is a positive thing.
Very exciting. Libby, did you have something you wanted to add?
I just wanted to pick up on Lorraine's point around building capability and just thinking about the community. So it's not all just about health. It's not all just about our organisation. To reach the critical mass that we want to reach, we have to reach outside of this organisation. So I know we'd be particularly interested in knowing what does that look like, Daniel, as you refer to, while people are waiting for an operation, when they're at home, what does that look like? Who do those individuals interact with each week? Is it Meals on Wheels? Do they go to the library? What does it look like? What does the messaging, what does the support look like? So that's, I think we need to think bigger than health.
Yeah, certainly think outside the box. So we've come to the end of our time, very short, and I feel like we could spend the rest of the afternoon unpacking a lot of what we've heard today. I don't feel like we've even scratched the surface or taken the first step. But I'd really love, before we wrap up, just for you to share a jewel of wisdom, knowledge, or a piece of information that you would love to share with the people in this room who may be thinking, what can I do? What is my role? Where am I going next? I'll give you a minute. I've thrown you on the spot there. As you can see, I've scarfed everybody. And
well, I've been trying to think of a slogan. And as good as it gets, challenge the balance is as good as it gets so far today. So I reckon we do a bit of a prize draw and, throw it out there and have some slogan from today.
Sounds great.
I had a bit of a story, maybe like the person that Karen helped, that my PhD started off in a conversation around how do we improve and decrease falls on a rehab ward. So I think, and I was never a researcher, never had planned to do anything like that. So I think some initial ideas can lead to some really good things. So I'd encourage anyone who does have ideas around research or projects to really get into touch with someone who's a bit more experienced, talk through the idea and see how they can support you into implementing it.
Gosh, I've got lots of things going on, and I'm thinking about your comment, Jacqui, on osteoporosis and how we communicate with our older populations. And I'm going to personalise it a bit with my mother, who had a serious fall and ended up in residential aged care as a result of it. And she hated exercise. Could never convince her to do exercise, really. We did get her to do some Tai Chi at one stage. The thing I think that would have made a difference, and Jacqui, when you said mopping and dusting, she was a great mopper and a great duster. So I think we need to reflect on how we have these conversations, because some people might be active in different ways and they don't see it necessarily as exercise. But in her case, I actually think that probably exercise and continuing with Tai Chi was helpful, but the discussion around osteoporosis didn't happen effectively with her, and I think that was part of the problem in terms of her care and what happened. So just in terms of the populations we work with, I guess it's around, what do you normally do at home? What are the activities that you're normally engaged with? What can we build on in regards to that in helping you to become more active when you go home from here? Or when you're in community, what else can we do, and how can we build in a component of exercise, if we use that word, that will make a difference and help you improve your function?
My jewel's going to come from my personal experience. Unfortunately, the last couple of weeks, I've had a relative in one of our acute facilities post-fall and hip fracture. So my jewel would be to never forget that behind the fall, there's actually a person.
I guess mine's also from a personal experience. So every year I decide that I'm going to do one particular piece of work around quality improvement. Every single health professional, we should all be doing quality improvement activity on a constant basis. I use a year as my timeline, but everybody can choose their own timeline. But look at your practice and the area that you're practicing in and pick something. It doesn't have to be falls prevention. Pick something where you think there is opportunity to change and that you potentially can invest some time and energy in changing that. Work out your own timescales. For me, like I said, it's once a year. This year it'll be fasting prior to surgery for me, but that's how I work in terms of quality improvement. It's part of my work on a day-to-day basis. Maybe everybody think, what am I going to do for my own quality improvement activity in my area of work?
Wonderful. Some great advice there from the panel. So please join me in thanking this great panel for being here this afternoon. Thank you to you all for your time and support of the forum and for sharing your expertise. Thank you. Oh, wasn't that great? It was nice to have that little informal discussion and, you know, something a bit more conversational. It's great to break it up a little bit. So up next, we have...
So invite Eric and Hadiya to come down. I'll introduce you whilst you're walking down. So Eric is the Deputy Director of Pharmacy at St George. And beside his bachelor's degree in pharmacy, he also holds a postgraduate diploma in drug development and a master's degree in business administration. That's very impressive. His 17 years experience working as a hospital pharmacist, having worked in a range of clinical roles including spinal rehab, orthopaedic surgery, cardiology, respiratory and neurology. He's also worked as an associate clinical lecturer at UTS School of Pharmacy and senior pharmacist of medication safety at Prince of Wales. Eric is passionate about improving medication safety through system change and clinician education. And his fun fact is, when not working, Eric can be found playing ukulele and harmonica with his 3-year-old son. Well done, Eric. Yeah. Where are they? Come on.
Not that great.
And Hadiya is currently employed as a clinical pharmacist at Sutherland Hospital. And in addition to a bachelor's degree in pharmacy, Hadiya also holds a master's of clinical pharmacology. She has rotated through various wards, including surgical, respiratory, cardiology and geriatric general medicine. During her 3 years of experience as a hospital pharmacist, Hadiya has assisted in several audits and research projects, including her own retrospective study on de-prescribing PPIs in geriatric patients, a study itself inspired by polypharmacy. And your fun fact is that during her spare time, Hadiya enjoys kayaking, cycling and painting. So welcome, guys. Thank you.
Thank you so much for the opportunity to present today. I know it's very late in the afternoon, so we'll keep this relatively short. Hadiya and myself will go through the concept of polypharmacy and older people and its association with falls and some of the strategy we can employ from a pharmaceutical point of view, how to reduce risk of falls. And in the second part of the presentation, Hadiya would go through a case study, a real-life case study from Sutherland Hospital. Polypharmacy. So poly simply means many, and pharmacy means medicine. It refers to the use of multiple medication at the same time, usually on an ongoing basis. However, there's no consensus definition of what polypharmacy is. But in the literature, we know that most studies have used the numerical threshold of 5 or more medications at the same time. So in Australia, the Pharmaceutical Benefits Scheme data in 2018 and 19 show that about 40% of people over the age of 70 years or over would meet this criteria of 5 or more medication. They would dispense 5 or more medication on an ongoing basis. So polypharmacy has been seen as a consequence of living longer. The longer we live, the more medical condition, especially chronic condition. And the more chronic condition we have, the more tablets or medication we need to either to treat that condition or to prevent complication. You can see here about 1 in 2 people over the age of 65 would have 2 or more chronic conditions, as opposed to those that are younger, 1 in 8 for those that are age 15 to 44. But is polypharmacy always bad? The short answer is in fact, recent studies have challenged the assumption that polypharmacy is always hazardous or indicative of a poor care. This is not the case. As with appropriate polypharmacy, especially in the area of cardiology, studies have shown that appropriate polypharmacy actually can improve quality of life and also reduce mortality. So I guess the challenge for us as clinicians or as an organization is to balance or optimize medication to ensure that the benefits outweighs the risk. So a population-based study in England, over 5,000 adults, aged 60 or over a two years period, found that the rate of falls was 21% higher in people using 5 or more drugs compared with people without polypharmacy. Because what's interesting in this study is that the higher the number of medication, the higher the risk or the rate of falls. As you can see here, those people with 10 or more drugs, the rate of fall increased about 50%. I guess this is quite important for us, as we can, the most patients that we see on the wards will have more than 5 medications. So this kind of gives us a justification on how to target our intervention. Perhaps those with excessive polypharmacy, 8 or more medications. I guess throughout the different presentations today, we have covered a lot of this, right? Important to note, polypharmacy or medication by itself probably doesn't make much sense unless it will as one of the many risk factors. For example, a Parkinson patient who have poor gait, muscle rigidity, and so on. The disease itself will increase the risk of fall. But Parkinson medication, especially high-dose Parkinson medication, can also increase the risk of fall. So you can see the complexity, the interaction between the different risk factors. And to make things more complicated, the patient characteristic, liver impairment, renal impairment, might also affect how the drugs are metabolized in the body. So far we know that polypharmacy is associated with an increased risk of falls. But this is I guess, kind of a ill-defined concept, right? Polypharmacy. It does not account for the type of medication, the combination of medication, the evidence base behind all the medication regimen. So I guess researchers have gone one step further and looked at different groups of drugs that might increase the risk of falls, what they call fall risk drugs. So a cohort study in the US, over 1,700 participants, has shown that persistent polypharmacy with fall risk increasing drugs was associated with about 48% increase in fall injury risk compared to those without polypharmacy or without the use of fall risk increasing drugs. So you might ask, what are fall risk increasing drugs? They are drugs that have side effects that contribute to falls. For example, confusion, dizziness, blur vision, orthostatic hypotension, and so on. Because if you want to remember a few drugs, these are the drugs that are consistently associated with the high falls: antipsychotics, antidepressant, benzodiazepine, opiates, and antiepileptic. And how about fall-related injuries like hip fracture? We know that when we are starting an elderly patient on SSRI or opiates, the risk of hip fracture kind of double. It's about 2.5 fold compared to those without those medications. And when you try to combine them, like for example, if you start SSRI, which is antidepressant for clinical anxiety, and it doesn't work straight away, it might take 4 weeks for it to start working to the maximum effect. They might be prescribed a benzodiazepine. So SSRI plus a benzodiazepine might sound like a good idea, but starting them together increase the risk of fracture by almost 5-fold. So I guess what can we do as an organization or individual clinician? I mean, for one, to start with, I think is just to promote existing initiatives. We can monitor for polypharmacy, identify any patient that has excessive polypharmacy, 8 or more medication or 10 medication, and target our intervention that way. And we include ward pharmacists in the discussion so that they can conduct comprehensive medication management review. In the community, there's Medicare subsidized home medication review where GP can initiate home medication review as an accredited pharmacist to go to their home to do a comprehensive review. And it requires a prescribing plan. Obviously, work with medical team. The prescribing is very challenging, and it's important to get the patient involved, as a lot of the other speakers have mentioned, because it's important to let them know what are the benefits of stopping certain medication like benzodiazepine. For example, you want to let them know what are the benefits of cognition. They might feel less drowsy during the day, better cognition, and so on. And we know that sedative, benzodiazepine, their effect kind of wear off over time. So I think Professor Close has kind of mentioned that general medication review. There's no evidence to support that. But I guess the process of medication review, there's quite a lot of variability. I guess for this systematic review, it showed that medication review as a standalone intervention was effective in preventing fall-related injuries. But I guess the challenge of interpreting all these results is that different studies use different definition of medication review, whether it's done by consultation with geriatrician or with a pharmacist or so on. But I guess there's some signal that medication review does have a beneficial effect. A recent study has shown that in residential care, it's reduced the mortality rate about 5%. Obviously, we can argue all day long whether there's enough evidence to support that, but done properly, I believe that medication review is effective. And when faced with a complex list of medication, it's it's challenging for us as a clinician to know what medication to target. So there's a well-known tool like blood burden index, Pierce criteria, stop start criteria on how to identify some of these reflex medications. I won't go through it today, but you can look into it further on your own time. I want to mention that with all these tools, it's challenging to implement in a busy environment with emerging electronic decision support tools. Certain districts have piloted drug burden index in EMR, quantify the exposure medication with anticholinergic or sedative effect, and give it a score of more than 1 are considered high risk. So this can be used to prioritize patients for intervention, or it can be used to monitor need progress. So if someone starts with a DBI or Tuqiri, after you do a medication review or prescribing, over time you can monitor for a decrease in the score. I will stop there and I'll hand over to Hadiya for the next part of the case study.
I don't know if everyone can see me. That's all right. So I wanted to talk about a case study for a patient that was recently admitted to Sutherland Hospital. And I feel like her case is very applicable to today's topic of polypharmacy and falls. So just some background information. We've de-identified the patient, and in this case study, we're calling her Mrs. DH. She was very recently admitted to Sutherland Hospital emergency department on the 2nd of February, so just last month, with a fall and had increased lethargy and drowsiness. Just some history of her presenting complaint. She felt very normal that morning, other than a bit more drowsy. She had her breakfast and her morning medications and was mobilizing quite normally. She had an afternoon nap, and while she was napping, she rolled off the bed onto the floor through the bed rails, and she tried to get up and stand but fell again onto her right side. Luckily, her son was at home and was able to hear her fall and was able to call the ambulances and was brought into Sutherland Hospital emergency. Prior to the fall, the patient was mobilizing. Normally, she used the walking stick, but other than that, had usually an independent lifestyle. She cooked, did her own shopping, and mobilized freely at home. So the ED medical team was able to collect some information about the patient. She has known drug allergies. She normally lives at home with her son and his family in a 2-story house, but her room is located on the ground floor, so she doesn't need that many steps to access her bedroom. Overall, the medical team also ordered some blood tests, and overall her blood tests were within range. Her kidney function was fine, and so on. They also documented her medical history, and she's got type 2 diabetes, she's a bit obese, hypertension, high cholesterol levels, GORD, depression, a hysterectomy a few decades ago, and she has a history of recurrent UTIs. Now, one thing that I wanted to point out was when she got admitted to ED, the son brought in an old Webster pack that was dated back October 2022. But now it's February 2023, so it's quite old. And because the patient was confused and she normally manages her medications, the medical team weren't quite sure what she was currently taking. So they used the old Webster pack as a reference for her current medications, and I've listed them on the slide. I'll just quickly go over them. Aspirin, atorvastatin, venlafaxine 150, mirtazapine 7.5, pregabalin 25 milligrams daily, linagliptin 5 milligrams, and Ryzodeg, which the patient normally self-administers 60 units twice daily. Now, one thing that the son was able to say was that he couldn't find the current Webster pack for February. He looked around the house and couldn't find it. So there was some concern that the patient might have self-administered the whole week of the new Webster pack within a few days. So the ED physio examines the patient and notices that patient is not at her baseline. So the patient's admitted to the ward under the geriatric team, and the patient is reviewed by the admitting in the ward. They were able to interview the son a bit more closely, and it was determined that the patient saw her GP 2 days prior to her admission to the hospital, and the GP did play around a bit with her medications, and a few medications were increased, the quetiapine and the pregabalin. That the son was unsure it was the pregabalin, and he had stated at that time that it was 30 milligrams increased to 60 milligrams. And so the medical team requested for a best possible medication history and a reconciliation by the ward pharmacist. So the ward pharmacist conducts and obtains a best possible medication history using at least 2 reliable sources, notably her dispensing history and her Webster profile from her community pharmacy, and also a GP health summary and correspondence. And also some of the medications that were brought into the hospital. And I've listed all the medications as per the pharmacy medication reconciliation. And as you can see, some of the medications are highlighted in pink. I just wanted to add on a few things to what Eric mentioned earlier in his slides about some common classes of medications that can be contributed to falls in pharmacy. So the patient is on 2 antidepressants, mirtazapine 7.5 milligrams at bedtime, and venlafaxine 150 milligrams in the morning. But she's also, and the mirtazapine can also cause drowsiness as a side effect. She's also on pregabalin, which she uses for nerve pain, but it's an anti-epileptic as a class, and it can cause drowsiness as well. And that medication was increased 2 days prior to her admission. A morning dose of 25 milligrams was added by the GP. She's also on an antipsychotic quetiapine. The son had stated that it was 30, but it was actually 150. She usually uses it for behavioral issues. It's not as for for schizophrenia. So that is a really high dose. It's usually reserved for like schizophrenia. So that dose was increased from 100 to 150 milligrams daily. And also one other thing is that she's on a benzodiazepine, oxazepam, and she usually gets 30 milligrams packed daily in her Webster pack, but also she has a pack of the 15 milligrams that she self-administers when required in addition to the Webster pack. And that, the last time it was dispensed was on the 31st of January, and that box is completely empty, and it's the 2nd of 2nd of February. So there's a possibility that she's unknowingly, because has increased delirium, that she's unknowingly self-administered a whole Webster pack and a whole box of oxazepam. So there's multiple issues with the patient. She's a bit delirious. A stroke call was activated, but given that there's no issues with the CT scan, that was disregarded. And the other issue is with her medications. There's a possibility of psychotropic medication abuse. There's a likely consumption, as I mentioned earlier, that a full bottle of the oxazepam alongside the Webster pack was taken within 48 hours. And she's also had multiple previous failed attempts with deprescribing the oxazepam, and she's had been unwilling to get off that medication. And she's also on multiple classes of medications that have an association with increased risk of falls. And also she had a urinary retention, and she was started on antibiotics as well. Now, with the medical plan, the main issue was to help treat the delirium. And so the main step would be to rationalize her medications and see what we can deprescribe. So the first thing was that they decreased the dose of the quetiapine from 150 to 75, and eventually with the plan to slowly stop that medication. They've also ceased the mirtazapine, and they consulted psych team as well, who recommended to continue the venlafaxine dose because of her depression. And also there was a plan to slowly deprescribe the oxazepam. She was also started on melatonin 6 milligrams daily to help with her insomnia, and also on antibiotics to help with her urinary retention. Now, with regards to discharge planning, so the son was to go search through the house and look for any old Webster packs and any boxes of medications, and to return them back to the local pharmacy to either be disregarded or used in new Webster packs. And from now on, the son was to liaise with the GP directly with any new scripts and new Webster packs. And also for the ward pharmacist prior to discharge to liaise with the community pharmacy to get a new Webster pack made up before discharge, because in this case the pharmacy was a bit concerned about supplying 3-day supply for this patient, and also for the community pharmacy to supply a weekly Webster pack rather than the usual 4 weeks of Webster packs, and also the son to oversee the administration of all medications from the Webster pack, just to avoid any concurrent administration of medications. And also there was an outpatient referral to older mental health to help oversee her deprescribing of the oxazepam. Thank you.
Thank you, Eric and Hadiya, for that great presentation around polypharmacy and falls. Some really great points there throughout the presentation, and particularly highlighted in that case study. Thank you for sharing. Wonderful. So that brings us to our next presenter, which is lovely Lucy, who joined us earlier today. And Lucy's going to come up here and share with us a little bit about April Falls Month. So welcome, Lucy, back to the podium.
So yeah, April Falls Month 2023. So the theme this year is Better Balance for Falls Prevention. With the easing of COVID-19 restrictions, it's an important time to encourage older people to increase physical activity, embrace balance and strength exercises, keep socially active and connected, maintain a healthy diet, and overall to aim prevent falls in older people and promote healthy ageing. April Falls Month 2023 aims to encourage older people to get physically and socially active in a safe environment. Social engagement can boost quality of life, mental health, levels of happiness, a sense of belonging, fewer health problems, and help live longer. We've previously talked about this earlier, but benefits of moving in hospital are preventing the effects of immobility, such as pressure injuries, falls, prevent functional decline, maintain independence with ADLs, and maintain balance and coordination, and improve respiratory function, cardiopulmonary fitness, alertness and psychological well-being, length of stay, appetite and sleep. On the New South Wales Falls Prevention and Healthy Ageing Network, there are a number of different campaign materials shown here that you can access as part of your April Falls planning. Posters of different clinical areas, healthy ageing challenges, and daily physical activity sheets. For South East Sydney, the district plan is that we have a district April Falls quiz. The QR codes have been around the different rooms today, and it takes 5 minutes, so have a go. And that will also be put in an email by Kate Hackett, our district Don, as a memo for April Falls. We have merchandise to be distributed to all the facilities for their promotional activities for staff and patients. And we also promote a district choirs equipment survey for wards to use as a resource. We will be doing 2 on the polls articles for this forum and also for April Falls. And we do a promotion of the New South Wales Annual Falls Forum, which is on May 26th this year. We've created a district April Falls activity plan, which will be put on the Nursing and Midwifery intranet homepage on the April Falls month logo. This represents the majority of SESLHD's facilities from inpatient, subacute, community, mental health, and residential aged care facilities. And now I'll let Dan introduce the SESLHD Falls facilities leads and champions.
Wonderful. Thank you, Lucy. And it's really great to launch April Falls Month. We are a month early on March 1st. However, we wanted to get in early and really launch what is an exciting month across the LHD with many activities taking place both in the community, in our acute facilities, across the LHD, an opportunity for us all to get involved to learn more about prevention and management of falls and encourage our colleagues who may not be able to be in places like this today to hear about it, take that information back to our teams and our wards. So we're going to run through a bit of a list over the next 20 minutes or so, and we're going to invite each of our falls leads and champions from across the district to come and share with you for a minute or two a bit about what they're doing locally over April Falls Month. So I would like to invite down to us our wonderful Carly Mueller from Prince of Wales Hospital, who will come down and share with us a little bit about April Falls Month at Prince of Wales. When I find it on the slide deck that is now misbehaving.
Everyone get.
We did. Let's just champions. See if it'll come up.
That's right. You can leave it like that.
Hi there, I'm Carly. I'm the CNC of Comprehensive Care at Prince of Wales. My slide's not up, so I'll just chat to you. So one of the initiatives that the Falls Working Party was working on recently is that we chose 3 wards that had the highest rate of harm from falls, not necessarily the highest amount of falls, but the highest rate of harm. And so we went through their baseline data with them, process mapping, and then a project plan. And then each ward determined what project they wanted to work on according to their gaps. That is currently on hold because all of those wards are moving into the new ASB. So right now, the Falls Working Party has shifted their focus to new models of care in the ASB. And then for our April Falls month, we have a few activities going on. So we're going to have jelly bean guessing game. We're going to have 3 jars across our 3 programs that our 40 wards are divided into. And then the winner at the end of the month will get to keep the jar of jelly beans. It's going to be the last 12 months of the number of falls. So we're hoping to just raise awareness of the number of falls that occur in each program. And then for nursing, we're going to do nursing grand rounds and transition Thursdays as well for our new grad nurses to be aware of falls. And then for physiotherapy, they're going to do a Tai Chi Tuesday. So every Tuesday in April, they're going to do that at lunchtime. And then we also are going to do the April Falls quiz that the district developed. And we're going to give the whole month for each ward to do as many submissions as they can. And then the winner is going to get a cake with the little logo down there that you see. We're going to put that on a cake for the ward. And it'll just a little bit of extra fun for them. So that's what Prince of Wales is doing.
Wonderful. Thank you so much, Carly. I'll invite Olivia back to the stage to share with us a little bit about the activities underway at St George. And it's great to see the slides are working again.
I'm Olivia Pollock. I'm the Aged Care CNC at St George Hospital. So at St George, we're doing a range of activities for April Falls Month. We've got a lot of multidisciplinary team education planned for throughout the month. We're also doing a jelly bean guessing competition with the number of jelly beans corresponding with our falls rate or falls number during 2022. But one of the main priorities that we're looking at during April Falls Month is the promotion of our QI project around the Huddle Up tool, I guess. Thank you. So our project's called It's Time to Huddle Up. As we've sort of touched on some of these aspects throughout the day, the background to this is that post-event safety huddles are endorsed by the CEC as an effective strategy to identify contributing factors and put in place mitigation strategies to prevent recurrence. We know from our falls rates and analysis of our data here at St George that patients who have multiple falls during a hospital admission can significantly contribute to our monthly falls rate. So when we see big spikes in our monthly falls rate, it's usually attributed to patients falling multiple times rather than more patients falling over. So minimising repeat fallers can therefore have a positive impact on our overall falls rate, but also reducing the risk of harm from falls. Obviously, the more times that a person falls over, the greater the chance of them actually injuring themselves is. We have done a lot of work around this in terms of our review of our, particularly our serious fall incidents, and we have identified that there is not a lot of compliance with our post-incident bedside safety huddle and the effective use of the Huddle Up tool. When we look at our more serious incidents, those processes are not being consistently followed. And also the Huddle Up tool moved from being a paper-based form to being an ad hoc form in EMR late in 2021. So, that's still a relatively new kind of practice change for a lot of areas. So really sort of focusing on that as well. So basically an overview of our QI project. Late last year, we did a hospital-wide survey and we looked, this was a multidisciplinary survey, so not just nursing staff, it looked at allied health and medical staff as well, just to see what people's understanding and knowledge of the Huddle Up tool and process was. And our results of that indicated that there was quite inconsistent knowledge of who, when and how to effectively conduct a post-incident bedside safety huddle using the Huddle Up tool in EMR. We're looking to target now, I guess on the background also, we've had a lot of really good success, particularly in aged care, with the use of the Huddle Up process and the Huddle Up tool, both for post-fall huddles, but also for post-agitation or post-aggression huddles. And really, we found it to be quite a proactive process that we could put in place to help reduce the recurrence. We're looking to target a couple of inpatient wards to begin with, looking at not just who has the most falls, but the wards that may be having an increase in their falls rate, looking at some recent fall incidents, and also looking at staff engagement to make sure that we're selecting a ward where we've got the buy-in from that particular unit to actually, dedicate to the QI project. We've started to develop a range of education resources to support staff knowledge and confidence in conducting post-fall bedside safety huddles using the Huddle Up tool. Then we will then look to evaluate the effectiveness of those resources in those pilot wards that we select, and also considering our more serious fall incident in reviews, the documentation post-fall harm score 1 and 2 incident reviews. And then based on our results of that QI and the strategies that we trial, we'll look to implement them more broadly across the organisation with our ultimate goal to have a much greater compliance with this process right across the site. Thank you.
Thanks so much, Olivia. Great to hear about the work happening at St George. I'd like to invite Elham back to the stage to share with us a little bit about April Falls at Sutherland Hospital.
Thank you. So historically at Sutherland Hospital, we celebrated April Fool's Day in the atrium. We had a massive day full of activities, Tai Chi, and stalls that they were showcased in the atrium. However, this year, our working party, the April Falls working party, next slide, please. We decided to have a slightly different approach. We are meeting every week, and we have decided to celebrate the April month through the whole month of April. And including activities such as educations. Next slide, please. Weekly education sessions, and also some competitions for the staff throughout the month. Ashley and Claire will continue to do give it a go, education throughout the month. And also there'll be some colouring competition. We will have the April Falls Day celebrated in the atrium and include some fun activities and also line dancing and also the merchandise. So that's just a very brief summary. Thank you.
Thanks so much, Elham. Lots happening at Sutherland Hospital. If you're around, make sure you come up to the atrium and do some line dancing. Look forward to seeing that. Next, I'd like to welcome Ashley Webster from War Memorial Hospital to share with us a little bit about what will be happening across the wonderful campus at Uniting War Memorial Hospital at Waverley. If any of you work there or have been there, it's a lovely place, lovely setting. Thanks, Ashley.
Hi everyone, my name is Ashley Webster and I'm the Quality and Clinical Governance Manager at War Memorial and Chair of our local Falls Committee. So we have a range of exciting activities planned across the month in our inpatient, outpatient and community services. So our day centre will be implementing a tailored falls prevention program with sessions targeted at different aspects of falls prevention across the whole month. We have our multidisciplinary team combined teams forum, which is like our grand rounds on Thursday, the 6th of April, and our occupational therapy team will doing a Falls in Focus presentation to the broader MDT. Our physiotherapy team will be running an in-service on mobility aids for nursing staff, as well as all things for AMP for the broader MDT on the Tuesdays in April. Our OT teams will be facilitating a falls group every Thursday in April on naming the aid for preventing falls as well as identifying falls hazards. We're also continuing with our famous Funky Footwear and Socks Friday. We've done that, I think, for 3 years now, and there's always a competition for best dress. So that's been quite a popular activity we've had the last couple of years. We'll also be participating in the district falls equipment audit and promoting the district quiz to all our staff as well. And of course, the promotional bags for our patients across all settings. And I think as we've heard today, we can't treat falls in isolation. So thinking about what we're doing in terms of comprehensive care, we'll be continuing with a few key quality improvement initiatives. So we have on the go at the moment a patient-centred goal-setting project with medical, nursing and allied health participants in that project team. Continuing with an intentional rounding project with the implementation and evaluation of that. Finalising and evaluating a delirium screening project that's been running the last 12 to 18 months. And also a sunflower tool and behaviour support plan projects which are currently being implemented. Thank you.
Thanks so much, Ashley. Some great work happening at War Memorial. I'd like to invite Tonya from Garrawarra to join us and to share a little bit about what you're doing at the Garrawarra Centre over the month of April. Great to have you here.
So the Garrawarra Centre is a residential aged care facility. For those who haven't heard of Garrawarra, we are located between Sutherland and Helensburgh, and we're surrounded by the Royal National Park. We're quite unique in that we are the only state government-owned aged care facility in the district, and we take residents from all over Australia. We have 104 residents, all living with advanced dementia and complex behaviours. So these residents require increased level of support compared to mainstream aged care facilities. A little bit of background. Garrawarra has approximately 500 falls per year, resident falls per year. However, I'm glad to say that our injuries from the falls are relatively low. A couple of these initiatives that we have, I believe in keeping these injuries low, is one of the initiatives is a Garrawarra Falls Working Party, which is a team effort between management, clinical floor staff, and AINs who work together to develop these strategies. And the purpose of this working party is to look for gaps and improvements on a day-to-day basis. For many of our residents, our strategies is often a case of thinking outside the box. Another initiative in that Jacqui Close will be very happy with is our vitamin D supplementation program. And this is part of our falls, our harm minimisation strategy. So all of the residents on admission to Garrawarra are assessed for their vitamin D levels, and approximately 97% of our residents are on vitamin D supplementation. If a resident has had a fracture prior to admission, they are also assessed for osteoporosis treatment. Unlike hospitals, we are privileged to work in the residents' homes, so therefore we know our residents very well. And this allows our fall prevention strategies to be very personalised. And as dementia is a progressive illness, the strategies need to adapt and change as the residents' needs change as well. Additionally, we need to balance these strategies with the wishes and the preferences of the residents and their carers. We're always aiming to empower the residents and encourage their mobility and to be as independent as possible. So Garrawarra's April Falls motto this year is Attention for Falls Prevention, and it will put a spotlight on the importance of maintaining our residents' mobility and physical activity in order to help prevent falls. On the 6th of April, we will be holding a falls prevention showcase in our carers' garden. And it will be an opportunity for all staff, carers, families and the residents themselves to connect and participate in fun activities such as outdoor exercise equipment, obstacle courses, guessing competitions, educational displays and Tai Chi sessions. That's it.
Thank you, Tonya. And I can safely say that I am very keen to come down and do some obstacle courses. It sounds like a great range of activities and a wonderful place. So joining us next is Kim King from Royal Hospital for Women and one of her esteemed colleagues to share a little bit about what's happening at the Royal Hospital for Women. I must say, I do feel like this is an episode of This Is Your Life. Most of you are probably too young to get that reference, but bear with us. We've got lots of great people to share with you today.
Thanks, Dan. Shyama's here with me today. She's one of our new Falls Champions, and so I couldn't miss this opportunity to introduce her. So I'm Kim King. I work at the Royal Hospital for Women and work in the Macquarie ward. We're a gynae oncology unit, and we've been doing April Falls activities for the last 10 years. It's always a really fun day, and every year it's increased, the activities we do and who we engage. So in the gynae oncology unit, we've got a unique set of patients in that only 50% of our falls are in patients over 65. We have a lot of younger women who fall for various reasons. And so they don't always fit the same fall strategies that we'd use in the older population. So it's an issue we're constantly brainstorming. And our greatest success has been including the multidisciplinary team, which has been the theme of today's session. So Shyam and I have got so many great ideas to go back to our allied health colleagues who really once a day we get together to have a safety huddle, and that's really the core of our risk reducing strategies, in that we all get together. It's led by our NUM, Sally Watts, and falls is always on the agenda. Every day we look at who's at risk, and we really support the junior staff in looking at how they risk reduce for their individual patients. Because with our younger women, their falls risk is transient. They might not come in as a falls risk, but because of the medication and the surgery and cervical shock, they can become a falls risk. And even though there's not an injury, there's a potential risk for an injury there. Education always on the agenda, and what we've realised is having an education board right throughout the year where patients, their families and new staff, we have students almost every week of the year on the Macquarie ward, we have agency staff, so we can orientate them really succinctly to our fall strategies in just a few minutes by focusing them on that education board. It's bright, it's orange, and you can't miss it when you come up to the ward. Again, we use other strategies as mentioned today, like the post-incident huddle, and constantly thinking about new ways to engage the MDT. And after all the discussion, especially Kelly's presentation, falls and delirium, closely related. I think they're first cousins. That's definitely something we're going to be focusing on. And my vote for the phrase would be, falls is everyone's business. The same slogan on the T-shirts, because that's really worked for us, including everybody, the patient, the carer, the family in falls prevention. Shyama's going to talk about our April Falls Month.
Thanks. So this year for the April Falls, we are planning quite a bit of fun activities. So we are planning like a dancing, balancing activities for all the staff. And we also planning like a food store, which will be really promoting on the healthy foods. So we will be focusing the color, like color-coded foods like in orange and in the green color. So I think it will be fun. And then we will be doing really a lot of in-service education with the pharmacist and with the physio. So they will be coming and doing some in-service education from all of us. And then we are planning like a few activities like fungi socks or colored T-shirts. So we will be providing all the staff with all those things so they can come on that day with all those things and accessories. So things that we have planned that, yeah.
Great.
Thank you.
Thanks, Kim and Shyama, for sharing that with us. And you're right, falls is everyone's business. It doesn't just happen to our elderly or frail patients. So next up, I'd like to invite Amanda Chu from Calvary Healthcare Kogarah to share with us a little bit about what's happening at Calvary over that period of time. It's great to have all of our falls leads and champions here in the room with us today. We are missing Jo from Sydney Eye Hospital, who sends her apologies. But these are the people within your facilities across the district that you can reach out to for support, advice, guidance, connections and networks to help you and your colleagues around falls prevention and management. Hi, Amanda, welcome.
Hi, everyone. My name's Amanda. I'm the Falls Champion and one of the physios at Calvary. We have a bunch of activities planned through April, so we decided not to have it as just a day, but just spread it through all the weeks. So we're also going to send out that district-wide quiz and encourage our staff to complete that with a prize at the end, and do also a chocolate guessing competition similar to the jelly bean one. And then the OTs and the diversional therapists are going to be hosting a hazard room challenge on, we're calling it April 14th, so April 14th. And both patients and staff are going to be able to go into this room and try to identify different hazards that might cause falls. Then we have each week on the Thursdays, there's a new QI project that our physios are running, a dance-led class to help prevent falls. We're going to be doing a falls education talk fortnightly on a Wednesday, and that'll be run by both the physios, the OTs, and the diversional therapist. And also a balance or obstacle course competition in our inpatient department gym. So that'll be a couple weeks. And lastly, we're going to be running an outdoor mobility group and just incorporating, trying to get as many staff involved with the mobility group and encouraging the patients to come out with us. And we're going to plan on continuing on a lot of these events rather than only running them in April. We're planning on continuing the Falls education talks and the dance classes and the outdoor mobility group to continue Falls prevention year long. Yeah.
Thanks so much, Amanda. And I think April 14th is a hot contender now against April Falls Day. So we've got some competition. I'd love to invite Natalie Narunsky from Mental Health Services to come down and share with us a little bit about the work happening across mental health services in April Falls month. Welcome, Natalie.
Hi, I'm Natalie, and I'm representing the older person and mental health service at Prince Wales Hospital. Fun fact, risk of falling is exacerbated by mental health problems, such as an impaired mental status due to anxiety, depression, psychosis, cognitive impairment. So both the impaired mental status and fear of falling are associated with impairment of gait and balance. So management of falls prevention is challenging in this group since the medications prescribed, like the mood stabilizers that we've heard from pharmacy, psychotropics, antidepressants, as well as ECT, can also increase the risk of falls. So we start off with the challenges that older people start off with, plus the extra load that the mental health patients have. But however, we do look forward to April Falls Month activities because we have a fabulous time, just as other centres have been doing. And staff do look forward to it. They do like the T-shirts that we hand out every year. They like the sticky notes and the pens, because who doesn't like a sticky note and pen? And this year, the collaboration has taken place with our very enthusiastic NeuRa NUM, the OT on the ward, and our diversional therapist. Now, we know that from a lot of today's talks also, that education and communication around falls prevention increases falls prevention awareness and confidence in dealing with that. We also add the element of fun whilst delivering various activities around the area. However, due to the acuity of inpatients on the NeuRa ward, we focus more on staff in group form and one-on-one, and with our patients, it will be more delivered one-on-one as appropriate in their stage of treatment. Just another initiative that we spoke about stepping on, and mental health at NeuRa, we do have a stepping on group which runs ever so slightly differently to the regular stepping on. And that is due possibly, well, firstly, space. Space is always an issue, how many people you can fit in a room. But given the needs of the particular clients that we have in older persons' mental health, it's not easy to mix in the regular general population group that in the classes that are run at War Memorial or within Prince of Wales Hospital. So we have our own specialised group. We have the same guest speakers that come along. However, every guest speaker does get a little bit of a pre-talk about the clients, because it doesn't go always according to plan, and you have to be quite flexible and go off on a tangent and deal with the group that we've got. So you never know what's going to happen within the group, and that always is fun and exciting. And then when the group finishes, you know, the 7 sessions finish, they are so upset because they've enjoyed the structure and the routine of coming weekly to something. Most people, when they are discharged from NeuRa, we try to involve in the stepping on group, because that allows us to keep an eye on people as they're settling back into the general community. And then our difficulty then comes after stepping on. Where do you go to next? And I know that that's been brought up a few times today, because our group do not fit into seniors exercise classes run at the like South Juniors or the Juniors League Club or wherever. It just doesn't happen, and the initiative and apathy. So if we can try and work together with other centres, that would be fantastic. One of the new initiatives, and that's what you wanted to hear, was that we have been linked with AIM, the AIM for Fitness, and I think it's going under a new name, Healthy HAP, Healthy Adult Population, I think. And they run a gym class in the outpatients at Prince of Wales Hospital. And we've taken the Booster Stepping On group now to have a look at that. And they're able to take 8 of our clients, and they've got a special mental health type group coming to start there. And that's a really great initiative and something we're looking very forward to continuing. So that's something very nice. That was aside. Generally, April Fool's activities are great fun where we are. We have T-shirt Tuesday, where every Tuesday the staff will be wearing their orange and green T-shirts. We're also doing a wobble-free Wednesday, where there will be different activities. It's mostly aimed at the staff, because once staff feel confident in what they're doing, it seems to transfer along the line. So there'll be sit-to-stand competitions, there'll be the walking, balancing the line. We'll do some tandem stands, and we'll do some Tai Chi poses as well throughout the month. There are other cognitively exciting activities like falls prevention, word search, crossword puzzles, and these will be scattered all over for everybody to be involved in. One of the other things that we're introducing this year will be an online quiz. We did a few last year as well, but this time, I think what we've noticed is the abbreviations in notes from physios, and not everybody knows what they are, or specific activity, walking aids that are around that people don't know the name of them and what they're really used for. So we thought we'd try and encourage an online quiz around name the subject, or what does this abbreviation mean, or all these things that physios put on their assessments that none of us know. So we thought we'd try a bit of an education. Also, I will just add that with mental health, we don't have an on-site physio. So we get a physio from the general hospital to come onto our ward, and so it's an in and out, and sometimes we don't know what they mean. So that's the roundup from us. Thank you.
Thanks so much, Natalie, and love how you're in theme of sharing a fun fact with us. To wrap today up, to share some reflections and support us with completing today's evaluation, we have invited the wonderful Director of Allied Health, Claire O'Connor, to be here this afternoon to have that honour. Claire has been here all day since before 8 a.m, so we are very privileged to have you here. You have, but you've been here, which is wonderful to see, and wonderful to have you here and be a part of the day. So thank you.
Thank you, Dan. Thank you for the invitation. And to those I haven't met or don't know me, I'm Claire O'Connor, the Director of Allied Health. And I would just have to say, what an amazing and inspiring day. I'd like to congratulate all of the presenters for such fantastic presentations. As I said, I haven't been here for all of the sessions, but I did learn a lot, and I heard a lot in the sessions that I was here. So just as a bit of a recap, the reason that we're all here, falls the second most reported harm incident in the district, and the leading cause of injury-related hospitalisations. And I think the statistic around an older person visiting an ED due to a fall every 2 minutes and 20 seconds blew my mind. So I think that's really quite alarming. If we don't think that there's a reason that we're all sitting here, then that statistic on its own is enough. I've scribbled as I was listening to the sessions today as well. So falls is everyone's business, and we've heard today the importance of the multidisciplinary team in addressing the falls risks. So keeping the person at the centre to improve patient safety and patient experience as we review our current practice and models of care will allow us to identify the gaps and implement our change ideas more broadly. I think we heard some of the challenges as well as some of the shining lights that's happening in this space. I heard that we've got lots of guidelines about physical activity, but now the challenge is to get those implemented and off the shelf. That we have some simpler solutions, so things like the vitamin D in residential aged care facilities. And I will go and refill my vitamin D stock because that's currently run out. And I guess that we've got many opportunities to influence the physical activity levels of people coming into our service, whether or not they're coming for a falls-related event. I hope that today has provided you all with some inspiration, some food for thought, and that you can consider what you're going to take back to your clinical areas to share with your colleagues. I think we heard, and Lorraine and various other speakers talked about the multifactorial impacts, so things like toileting, mobilisation, pain management, hypertension, nutrition, hydration, polypharmacy, but there's so many factors that influence the falls risk. And as a speech pathologist, I was very happy to hear the comments around oral hygiene and the importance of oral hygiene in the prevention of aspiration pneumonia and those impacts on falls. What else did I note down? So I think the themes that were very consistent across the day were around the comprehensive care, so falls, cognition, continence, pressure care, medications and nutrition, and that we all have a role to play in reducing falls within our hospitals and broader community. So I know that I'm probably the only person standing in the way of you getting out the door. Maybe it's slightly behind Dan, but I will ask that you please complete the evaluation survey via the QR code that you would have received in the room, and I think online people have got that as well on the screen. And finally, I guess just to wrap up, that there's many people to thank in the organisation of a forum such as this and the success of a day like today. So to all of the presenters from all of the facilities across the district, the CEC, to NeuRa, and to our panel members and special guests, thank you so much for your time and your commitment to this important area. I'd also like to thank Toby Wilson and Kate Hackett for their support and endorsement of this forum, to the Working Party, and in particular to Jane, who stepped out for a minute, for her dedication, and to Dan for his MC skills. Well done. To Keystone for the lunch, St George for hosting us in this venue and actually being able to gather together face to face has been a really positive feature of today. And to Lucy for your vision, leadership and hard work in putting together the forum. I think Dan's got a few more comments to add to the end of that, so I'm just going to leave you with maybe Karen's comment from the panel discussion around remembering that at the heart of this is people and relationships, and that behind every fall there is a person. So that's the important thing that we need to remember, and maybe also adding in Jacqui's comment around having a goal around a QI project on an annual basis so that together we can make a difference to these falls risks for our community. Thanks, Dan.
Thanks so much, Claire. Couldn't have said it better, and a really great summary of some of the key points from today. I just wanted to follow on from the thanks that you shared to all of our invited guests, our speakers, our executive sponsors. I'd really like to thank all of you for being here. And for those online for setting aside a day to come and be involved in a forum like this. This is the first time that we've ever held a Falls forum across the LHD, and we've been overwhelmed with the number of people registering to join us virtually and face-to-face. We could have filled this auditorium twice over, but we didn't want to force everyone to sit in masks all day, so went with the option of a hybrid model. And I think moving forward, we'll see this event grow. It's no easy task to get a day like today together. It takes a lot of logistics and planning and is often something that is on top of everyone's existing workload. Our Falls in Focus working group have been working really hard over the last 8 to 9 months to bring today into what you've seen, into reality. So I'd like to thank all of them for their hard work and their dedication. Round of applause. I'd like to thank our representatives from COTA. Camilla, great to have you here. Give us a wave. Wonderful. Our health promotion teams, MedApp, our partners from Keystone and across the district, and thank you to Keystone for sponsoring lunch. It was really wonderful to be able to provide that for everyone today. And our team here today, without you, it wouldn't be possible. Kelly, who you all know from presenting earlier today, has been running around behind the scenes, helping today come together. Deb, who was on our registration desk, who is just a warm ray of sunshine, and it was so lovely to have her here for today. Ali, for manning the chat and keeping our online guests conversing with each other and keeping them up to date. To Kate, our Director of Nursing Midwifery, who has been in and out today, for her sponsorship and her support of putting on a day like today. I think her head nearly fell off when Lucy and I went to her and said, we have this big vision and we would love to do this. And Elizabeth, for all of your support in the lead up to today and being here today and doing some of the timekeeping for us. It's been great. But I'd really love to direct a lot of my thanks to Lucy. Lucy is one of the most hardworking individuals I think I've ever had the privilege of working with, and I'm so blessed to have Lucy as part of my team. I think today is testament to your hard work, your passion, your tenacity and your drive. And I know you are very well respected across the LHD, and we're also thankful to have you helping us, guiding us and leading us in the fall space. So thank you very much. And that's it.